Esteemed colleagues, brothers and sisters, Sairam. I will begin with a quote from Swami. Do not believe that you can, by means of service, reform or reshape the world. You may or may not, that does not matter. The real value of service, its most visible result, is that it reforms and reshapes you. Do service as a spiritual discipline, then you will be humble and happy. So I want to make two announcements before we get to Mayur's talk. The first is we need two things for CME today, a CME form and a signature form. Forms must be turned in by end of day. As you make a left outside the exit, the forms are available on your left-hand side. We have a break at 10:30 a.m. and a break at 12:30 for lunch, so hopefully we can get all the forms signed by that time. So let me begin by introducing Dr. Mayur Narayan. Mayur Narayan is an attending trauma surgeon at Weill Cornell Medical Center. He has both an MBA and an MPH from Johns Hopkins Medical Center in Baltimore. He also recently received a Master's of Science from Harvard Medical School for medical education. He is what I think is his most impressive attribute is that he has 2 awards for excellence in teaching with 2 Golden Apple Awards, which is not easy to get. So without further ado, Mayur Narayan.
Sairam, and good morning to you. Let me start off by thanking Dr. Reddy and the organizational committee, brothers Joe, Hari, Ganesh, and Vijay, for inviting me to give this talk with you this morning. So I'm a trauma surgeon, and the topic is Hands That Serve, a Trauma Surgeon's Journey. Initially, when I chose this field, Mom and Dad weren't really sure about what trauma meant. They were very happy that it had the word Rama in it, and they said, it'll probably be okay. I have no conflicts of interest to disclose. Let me tell you a story. This may not mean anybody to anybody in this room. This is my Tauji and my Taiji, my father's older brother and sister-in-law. He was the director of fisheries in UP. And as it goes, they were traveling from Lucknow, which is the capital of Uttar Pradesh, the state where I was born, to my ancestral home in Bareilly to visit my grandfather. En route, they met with something like this: a small Maruti car, a drunk lorry driver, and they were taken to a small hospital alive. There, the physicians diagnosed them with obvious extremity fractures, missed the internal hemorrhage, and they died 4 hours later. The eye couldn't see what the mind didn't know. This is 2001. This is where I did my training. This is at the same time I was a 4th-year medical student in Norfolk at Eastern Virginia, deciding what I was going to do with my career. And this incident happened, and it clearly made an impact on me as to what I was going to do with my professional career. And so I had an opportunity later that year in 2001 to visit Swami, and in darshan line said, "Swami, I'm thinking about surgery." And as many of us received, a slap on the face that said, "Very happy," and then he moved on. And I took that to say, this is how my journey is going to start. For the youngsters in the room, I put this picture up for a reason. I think it's very important that you choose mentors in your life that are going to guide you, not only within the organization, but in your own specialties where you are. This is Dr. L.D. Britt, who's the chairman of surgery at Norfolk, who took me under his wing as like a father to me, and who has motivated me to do the work that I'm doing in trauma critical care. And he's still one of the master educators in the country. He's done phenomenal work. This is Dr. Wilkes Hubbard, a thoracic surgeon who showed me the art of medicine in terms of bedside manner, sitting with your patients. on evening rounds. Still does it to this day. My residents don't like it as much because it takes a lot longer. But his patients loved him. One of the senior surgeons of the Norfolk Surgical Group, and an unbelievable soul. When I left Norfolk, I then went to Baltimore. This is the Shock Trauma Center. It is the busiest trauma center in the country. It sees about 8,500 trauma patients a year. Their motto is "Where life is on the line," and I'd like to make you remember that for a second. So trauma is a disease, and we are all public health servants, so I would say trauma is a public health disease. It is time-related. Volume matters. It takes time to mature the system. All of these are relatively new concepts within the last 30 or 40 years, and many of them started in Maryland. So if you take a look at this graphic, patients with shock, and how many admissions it takes to make an impact, it takes several hundred before you become a mature system. And if you look at crash mortality as a function of first trauma center designation, you can see the number of years it takes before you start to see an impact in terms of mortality. This is Dr. R. Adams Cowley, for which the Shock Trauma Center is named. Many of you all will know him as the father of the golden hour, which is this following slide. But he was a US Army trauma surgeon. He created the first comprehensive system, and really is credited for the first EMS and air ambulance system in the United States. And so there is a golden hour of death between life and death. If you are critically injured, you have less than 60 minutes to survive. The exact time is not that important, but you might not die right then. It may be 3 days or 2 weeks later, but something has happened to your body that is irreparable. That's very true even today. This is the old Shock Trauma Center, which is a 2-bed hospital called the Death Lab. This is where they did experiments to try to save people who were in shock, in traumatic shock. It then went to a 6-bed hospital. And then finally, we can see what happens in terms of survival, in terms of the golden hour. Survival is related to severity and duration. This is the Maryland EMS system, a system that I grew up in, and look at the number of helicopters. This is a very nice slide. It's a very busy slide, but it tells you for a small state like Maryland, we had 8 helicopters. I was giving my first international talk in Kottayam in Kerala, highlighting how awesome this system was. And along the journey of becoming a trauma surgeon, one gentleman stood up in the back, folded his hands and said, "Sir, that's very nice. We don't even have a rickshaw to get the patient down the street." A great lesson to learn that you can't just duplicate the system that you have and take it to a developing country. An important lesson for me as a young trauma surgeon growing up. But if you look at the flight times anywhere within the state, you've got about a half an hour time to the mothership, which is the Shock Trauma Center. And yes, it's fun to recognize the people, the men and women who bring these patients to you. Each day they're sacrificing their lives so that we can have the patients brought in an expedited fashion. And these are some of the men and women that fly our patients. I got a chance to fly with them. I've had some unique experience in the critical care arena as well, molding the journey in trauma and in acute care surgery. Some of you may recognize this face. This is a gentleman who was suicidal. Mental health issues are very problematic in our society. This is a self-inflicted gunshot wound to the face. This is the team with Dr. Ed Rodriguez, who's the chair now of NYU Plastic Surgery Department. When he was with Baltimore, when I was in Baltimore, we worked together. There they did the operative work, and look at the result that they gave Richard Norris. I got to take care of him in the ICU setting, and take a look at this slide. A man who had entire face transplant becomes a GQ model. And this is Richard on a visit after his recovery. You can see that he's doing quite well. Another patient along the journey, Towson football player Gavin Klass, came to me with a temperature of 108 degrees Fahrenheit. You can imagine what that does to the body's function. He was in complete liver failure. He was going to die. This is his parents. You can imagine he's 20-some years old. They were very, very distraught. And we initiated for the first time in Maryland the MARS system. It's the molecular absorbent recycling system. It is basically liver dialysis, bridging him to transplant and bridging him back to the point where he now wants to play football again. I told him I thought it was a horrible idea. I would be a cheerleader on the sideline, but what got him through this is probably what is going to get him through this as well, the football aspect of it. Being in Baltimore, I had the unfortunate scenario of seeing the city under fire. Many of you remember Freddie Gray, the incident when he was brought and he actually died while in police custody. And this is what Baltimore looked like. And it got worse that night. The city was basically on fire, and this is what was going on. I happened to be the trauma surgeon who was on call that night, and you can imagine the anxiety that we were facing. You have to ask yourself, we had a mindfulness thought, couple of mindfulness talks yesterday, as to why this would be going on in Baltimore. And as luck would have it, Lifetime was just filming us from the shock trauma side of things, not expecting this to come in, and this is when 10 police officers came in with bricks to their face, and they were injured, and they happened to catch this picture. It was a very distressing night. And this is the media that you saw all over, that the city was burning, and we did not feel comfortable until the military came in, National Guard. The city got better. There are still underlying issues, many of which I'm passionate about, including penetrating gun violence in the inner city. Well, I changed focus and I moved to Johns Hopkins, where the motto is, we save lives millions at a time. The world is flat. This is the emergency acute care as a global health priority. I think everybody would recognize this. Haiti, we've talked about yesterday as to the impact that we've made as an organization. Puneet Kyle and I were just talking about how it's so hard in residency or in fellowship to go, or if you're working, and that you can give back even though it's not through an organizational branch. Do what you can within your own arena. That's still Seva. And take a look at the pictures. You've seen all this. This is, I thought, was a meaningful slide for me. We were Team 7 from the Shock Trauma Center to go down. We need help. We worked at the St. Francois de Sales Hospital, which is 140 beds, largest private teaching hospital. It was completely collapsed. You take a look at the wards there that you see. It was kind of eerie that the funeral home across the way was standing still where the hospital was in rambles, which is a very bad omen for us. It was very eerie. USAID helped, that's me and my boss rounding. And these are some of the things that we saw. Not so much in the acute phase, but people who came to do good and then left. And you heard people talking about doing Seva when you're going to a country and you're going to stay. It's important to do long-term work, not just short-term work and then leave. You may end up doing more harm than good. This is the shock trauma team that went down. We've done some work in India. The journey continues. I'm passionate about trauma care. It is my life's mission to train pre-hospital providers and to train trauma specialists. I linked up with the All India Institute of Medical Sciences, where I've been a visiting professor for the last 5-6 years. This is Dr. M.C. Mishra, who was a visionary and established the JP Trauma Center, Apex Trauma Center in Delhi, the first of its kind, really pushing the envelope for trauma care. We all see this. This is a common site. And for my MBA, I did a capstone with EMRI, which is the 108 Management Institute. Got to really get into the trenches to see what this looks like. Important lessons for us. Again, I'm in north of Hyderabad, and I see this diagram or this picture of Dr. Cowley on the wall, crediting him as the father of the golden hour, which I thought was very, very neat. I did not expect to see that in Andhra. And of course, this past year, what an amazing event. 15 years after my aunt and uncle died, we had the World Trauma Congress in New Delhi for the first time. Trauma specialists from around the world, we came together to highlight what's happening in India and also around the world. This is the Indian American Surgical Association I've put together, helped found this organization. We're in our 5th year, try to bridge Indian surgeons who are here and practicing and doing work and Seva projects in India. This is Dr. Ajit Sachdeva. Many of you know him. He is the director of the education wing of the American College of Surgeons. He was given the Lifetime Achievement Award. And that's Preeti John, who's one of my former partners who did a book on women in surgery, which is a unique offering. Swami's taken me to China after the earthquake there to do training in Chinese, although you have translators, but it's been an unbelievable experience for the past 5 years, giving back to them. Love knows no language boundaries. It's been an unbelievable, rewarding experience with the Chinese folks in Chengdu, China. I had an opportunity to go teach the White House Medical Unit trauma training for their medical unit. And this was a complete highlight of my young career as I was starting, unexpected. Of course, I didn't get to meet President Obama. He left, so I got pictures with Sonny and Bo, and so I told my mom again, well, I didn't meet the president, but I have a picture with the dogs, and she said, that's very nice. I'm passionate about trauma because I'm a patient. This is me post-call. I had worked 40 hours, gone home, and then the next thing you know, I fell asleep at the wheel. I'm smiling in this picture, but I wasn't smiling when they rolled me back in, still in scrubs, to the hospital. Trauma hits home, it's personal. And so I'd say the best patient is the one we never see. And I'm committed to injury prevention. Injury prevention includes things such as pre-event, event, and post-event, things related to the agent, the host, and the environment. This is why we call them crashes and not accidents, because somewhere along the spectrum, we can prevent something from happening. I created the Center for Injury Prevention and Policy in Maryland. One of the first things we worked on is texting and driving. And I want to show you, this is a free video that we created in Maryland. If I can go back. Pole goes through the lady's mouth. You can see the EMS responding. They cut open. This is a video, graphic video, 17 minutes. The helicopter lands, patient goes to the hospital. We took this to the Motor Vehicle Administration of Maryland, and they made it mandatory viewing for all new drivers in the state of Maryland, which I think is a public policy victory for us, in conjunction with all of the partners that you see there. And so trauma care concepts, as I'm going to summarize here, everybody knows the ABCDEs. What can we do to make a difference? How about always bring compassion during engagement? Those are my ABCDEs. And it's more about the next generation of medical students that are coming down the pipeline. Here's the need. Is there hardening of the heart during medical school? Yes. Students lose empathy for patients during medical school. Does medical school erode student empathy? All concerning things that we're seeing. So what are we going to do about this? This is the taste of chocolate that I like to teach with students. Taste of chocolate being that it's hard to describe what it really tastes like. I play this game with all my students, residents, and fellows. They go down, they give the adjectives. I said, when do you know the taste of chocolate? It's when you put it in your mouth. And then I take any one of the diseases that we're learning about to say, do you have any idea what this tastes like? One of my students just wrote to me early this morning saying she published a blog having put an NG tube in herself for this very reason, to get an appreciation for what her patients are going through. We spend 5 minutes with our patient, and then we're off and running to the races. I think it's a reminder for us to slow down and spend some time with the ones that we're caring about. We created the Humanism Symposium, last 2 or 3 slides here, a full course designated to humanism in practice. This is coming from the medical students. I happen to be the course director. Meaningful course that's still active today at the University of Maryland, something we can do, everybody in this room can do in their own environment in terms of what are the tangible takeaway points. And this is our first guest speaker, Danielle Ofri, for the Humanism Symposium. Finally, the last slide, this is Cornell, where I am now. Stop the bleed. Many of you have heard me talk about this. This is very important. It can happen anywhere in terms of your injury. You've seen this happen in New York, Boston, London. There have been 74 school shootings since Newtown. We must, each one of us, commit to helping learn this simple skills, which are these. Who can respond? Trauma professionals, and immediate responders. But by the time somebody gets there, that person has died. Apply pressure, apply dressing with gauze, and apply a tourniquet. That's it. Anybody can learn this. I urge each one of you to please learn this skill. It takes about 40 minutes to learn. You become certified, a tangible takeaway point. We're doing this for 300 businesses in New York. This is going to be our community outreach project. I want to thank you for the opportunity of the podium. It's been a pleasure. This has been an awesome conference, and I look forward to interacting with you all in the future. A loving Sairam.
Fantastic talk, Mayur. That was wonderful. The golden 16 minutes is definitely a helpful rejoinder to everybody. Our next speaker is Dr. Anil Nanda. He was chairman of the LSU neurosurgery department at the age of 31. Let's let that sink in for a second. Since then, he has continued in that role. He is now the director of the board that certifies neurosurgeons, the American Society of Nuclear Surgery, American Board of Nuclear Surgery, and he did not rest on his laurels. In 2012, he went out and obtained an MPH from Harvard, and his passion now is preventing football injuries and CTFE in NFL players. So without further ado, Dr. Nanda.
If you like the taste of chocolate, once you've tasted a Sai Laddu, your life is never the same. So thank you again for this opportunity, and I want to thank Dr. Reddy and Venkat and all of you that put on a great show here. You know, at the end of the day, we're all family, and I think it's wonderful to be with family. It reinforces the mission, it heightens our devotional intensity, and it makes us better people. So it's very uplifting. And I picked sort of a strange topic to talk about, because I thought I'll talk about toxic doubtlessness versus uncertainty, because toxic doubtlessness connotates a certain hubris when we take care of our patients. And I think no talk would be complete without obeisance to a wonderful medical mission. I think Sai Healthcare is inspirational. And I think in the immortal words of the master, love all, serve all. I don't think you can add anything more to that. So Harvey Cushing was the great endocrinologist, you'd like that, neurosurgeon, anesthesiologist, he discovered multiple fields. But his great line in Consecratio Medici is that there is only one thing that can effectively define people or bind people, and that is a common devotion. And all of us are here today because we do have a common devotion. We have a devotion to ideal healthcare, to compassion, to kindness, to universal access, and to care for all. So this talk really stems from an editorial in New England Journal of Medicine that they talked about medical uncertainty. And John Keats, who went to medical school, was an amazing poet, and he says, "At once it struck me that quality went to form a man of achievement. But a man, I guess, and woman, to be politically correct, is capable of being in uncertainties, mysteries, doubts, without any irritable reaching after fact and reason." And that's sort of this concept of equanimity. And it goes back to Apollo. Apollo was the god of medicine and poetry. And if you look at the poetic traditions in medicine, you know, Oliver Wendell Holmes, John Keats, William Carlos Williams were all physicians that wrote exquisite poetry that we all get inspired by. And if you look at the physics, I mean, I put this in specifically for Venkat because people don't realize he had a PhD in theoretical physics. But the Heisenberg principle of uncertainty was that you don't know the mass and velocity of a particle. And that sort of questioned the hard facts of physics and science, that there is a mysterious element to all this. And that's something we should always talk about. All science starts really from doubting Thomas. So if you look at when the resurrection of Jesus happens, Thomas is not content to believe. There is an element of uncertainty. And he says, A, I want to see the wound, and B, I want to touch the wound. Only then is he convinced. And if you think of all science, it starts from that. You want observation and you want confirmation. So he touches the wound, he figures it out, this is what's going on. And I think this mythology carries in many traditions. I always feel that my Ishtadevta, Lord Shiva, was really the first neurosurgeon, because when he does a brain transplant on Lord Ganesha, that is neurosurgery starting off. And if I was just in Botswana and you see these beautiful elephants, 100,000 elephants in Chobe, and you're like, oh my God, this is Ganesh all over the place. But I know there's cardiologists in this audience, and I know Dr. Desai is there, and in deference to the cardiologists, the Egyptians felt that the brain was no good. When they mummified the people were mummified, they didn't worry about the brain. They put a suction into the nose, suction all the brain off, it wasn't important. The heart was important, and the spinal cord. So a deferring mythological statement there. But really, the guy who really talks a lot about uncertainty is Osler. And I will come back to Osler a lot. He's really the father of medicine. His great talk on equanimity and the way you handle things. And he said medical education is, to a large extent, is education for uncertainty. And I think what I'd like to leave you with is a sense of openness, that we do need doubtlessness. We need to make a diagnosis. We need to cure disease. But at the same time, there's something fundamentally mysterious. Sometimes you should be open to that. You should not be rigid to that at all. So let's look at the history of medicine and how these traditions came. Bloodletting for hundreds of years was the standard care of taking care of people. So you opened up their veins, you drained them, and everybody had an element of toxic doubtlessness. They said, this is the best thing for you. From 2,500 years ago, you look at Greek vases, they had this. You look at 1517, taking care of wound medicine. William Harvey believed in it. Vesalius, John Hughes Bennett, and they were casualties of this method. So if you look at what happened to George Washington, he had a little pneumonia. He might have survived that pneumonia, but they put him up, and they drained him, and guess what? He's dead. In fact, the first malpractice case in America starts with that because people start whispering against the doctor that took care of him, like, you messed it up. Charles II dies that way, same thing, bloodletting blunders. But there's also another side to it. Sometimes our doubtlessness works against medicine. So we know in the journey in 1497 on Cape of Good Hope that they gave citrus fruits to people and prevented scurvy. Okay? It goes 250 years after several trials before they make it mandatory to give you citrus fruits to prevent scurvy. So doubtlessness goes in the other way. We are rigid to adopt innovation. But disruptive innovations in medicine come from so many heroes that questioned everything. They had uncertainty in their mind. Ambrose Paré was the barber, the great surgeon. In those times, if you had a wound on the battlefield, they put hot turpentine oil on you. Well, he decided, he ran out of turpentine oil. He was so nervous, he put rose oil on the wound. And lo and behold, people did better. Same thing with Joseph Lister. He comes up with the carbolic acid, anesthesia, makes surgery safer. Florence Nightingale is the diva of public health because she comes up with the charts during the Crimean War and saying, my God, your troops are dying because your hospital is dirty. You know, she questioned this whole thing. Same with Marie Curie, gets 2 Nobel Prizes, starts radiology. And then, of course, our great personal master, Harvey Cushing. But I think Barry Marshall's story is very good. We grew up doing vagotomies. When I was in India, the commonest operation we had, if you lived in the South, everybody got a vagotomy. It's all the masala stuff you're having. In the North, you got the gallbladders because you're eating too much laddus. In the South, you got vagotomies. There were hundreds of vagotomies, hundreds and thousands of vagotomies. Well, Marshall and Warren say, maybe there's something else. And people laughed at them. So he injected Heliobacterium on himself and gets a peptic ulcer. They get the Nobel Prize for that. Again, uncertainty led to a disruptive innovation in medicine and changed the way we thought. But we've had disadvantages. You look at lobotomies. In the 50s and 40s and 50s in the United States, the commonest operation. Freeman Watts would go into psychiatric institutions, do 15 lobotomies, and there was a gender bias. They would do it more on women. They would do a bunch of lobotomies on them and say, oh, we got to get cured. Never worked, was a disaster, and we weren't doing the right thing. So I want to talk a little bit about my personal experience. We sometimes get very comfortable with what we do. I've done 17,000 surgeries. I've done like 6,000 craniotomies. I think, toxic doubtlessness. I know what I'm talking about, okay? So, I've done over 1,000 aneurysms. This is what I sort of specialize in. It's a little niche these days. Medicine is so specific. You're taking care of ingrown toenails, and you're the world expert on that. And I take care of skull-based tumors. This is something that I write a lot about. And I always like fields where there's intellectual cross-pollination. And so we are here today looking for ideal sign healthcare, and all of us bring something to the table. And what we leave with is not only a common devotion, but an intellectual cross-pollination. So you look at this, and this is how our field started. We published a bunch of this. So there's a little hubris here. I know this, I've done this very well. So I'll give you a small example. This happened to me 3 weeks ago. 62-year-old female, severe headaches. This is her CAT scan. She had a subarachnoid hemorrhage. She had large aneurysms. I may not project that well, but one left, one on the right. If you can play that video, please. So this is very routine procedure. This is the giant side. Can you press that? Can you just press that on that? So this is pretty routine. Just going in. She's a smoker. This is the optic nerve. We're doing routine surgery. Everything looks good. I don't drink, but our residents say it's Miller time, and this is going on. Everything looks good. So you can see here, this went very well. And, we were very comfortable with the result. Everything was fine. Here we're putting a clip on the carotid, and then we reconstructed. And we were quite pleased with this. This was the tough aneurysm. This is the giant aneurysm. Normally with these aneurysms, the complication rate is about 30%, 35%. It's a difficult thing here. We're burning it. We're sort of fine. So the other side was the easy one, okay? So I was like, okay, this is fine. We did well. And I did this, I think, in January sometime. So no, actually it was February. So she comes back 4 months later, still a heavy smoker. You know, we got to talk about this. People don't listen. So we fixed this. And I think the brain is so beautiful. I always have to take a little diversion, you know. I can't believe they pay me to do what I do. I just love the brain. Every time I look at the brain. For the younger people in the audience, you know, Wordsworth had a wonderful line, and then our heart with pleasure fills and dances with the daffodils. He loved daffodils. And I would tell the younger people that you should pursue your art like you look at daffodils. You should feel that love. And every time I look at the brain, I'm like, what a privilege. So, you know, the art of the brain is always fabulous. This is Gerard David's Transfiguration of the Christ. They always look for the brain in different things. I'd like to remind Dr. Desai, they don't look for the heart in that, just sort of a little professional point there. So, you know, we published this. We have a book on this. And again, I've published on these aneurysms, giant aneurysm. These are my results. So, can you play this video? So, I'm doing this 3 weeks ago. And it's almost like Swami said, this is the case you need to show. Okay? So we're doing this case, and you know, everything is fine. My tension is off. I took the big one. That was the high risk one. This is the easy one, okay? And here it is. It's a giant, it's a smaller aneurysm, it's about 1 centimeter. And we're taking a little piece of bone off right there. And you know, we're like, this is good. We're going to be fine. I'm like looking for the next case. You can see the optic nerve there. And then we come closer, and we're going to take another piece off. And you're like, this should go well. And you can see I'm going to take another piece off here. And there it ruptures. And you know, this is where your doubtlessness, what do you do? And as Lincoln put it best, sometimes all your answers come when you're on your knees. And I've repeated this before, and this is just personal for me because Swami always used to say, you know, when Draupadi was disrobed and she goes to Krishna and says, like, why didn't you rescue me? And he says, you said Dwarka Mai. I had to come from Dwarka. So if you had said Hridayvasi, I would be right there. And I always say Hridayvasi. I'm like, I'm FedExing for help here, Lord. You better bail me out. And all I can say is he always does. Or as my mother would say, it could be she. You don't know. I'm like, yes, ma'am. So you could see, so we were really blessed on this case. We were able to reconstruct the carotid. And I think this is when, I think for the younger people in the audience, that you really need to be able to do an autosympathectomy on yourself. That you have to have Oslerian equanimity. Because if you lose it, you're going to lose the patient. And I think that equanimity for Sai Healthcare, for compassion, is extremely important, you know, that you have that. So we're very blessed, she does well. But, you know, I think I call these moments memento mori. You know, when you look at medieval popes, and even Queen Elizabeth I, she would wear a watch with a skull on it. Every time she would look at the watch, she would see a skull. It's like, remind you of your death. When the popes in the medieval times were inaugurated, there'd be a guy at the back whispering, sic transit gloria mundi, life is brief, okay? And I love poetry, and I think this is a wonderful poem by Agamemnon that I read with my residents when we have a complication. And it says, God whose law it is that he who learns must suffer. And even in our sleep, pain that cannot forget falls drop by drop upon the heart. And in our own despite against our will comes wisdom to us by the awful grace of God. This is one of the great poems. When Martin Luther King was assassinated and Robert Kennedy was in the city of Los Angeles, they told me to get you out of this neighborhood, no speech, you're out. And he says, no, I'm going to give a talk. They're like, okay, we'll write the talk. He says, no, you're not writing the talk. And he says, this was the poem. He talked about his brother's death that he had never talked about privately or publicly. And when Martin Luther King dies, he recites this poem and says, this is what got me through what I went through. And I think it's a wonderful piece. And there's a whole thing on second victims, that people who have this, that we do get second, and as physicians, we do not handle complications that well. And we take it very lightly, like I'm tough, I can handle it. And I would urge you that, you know, whether it be meditation, whether it's go to satsang, it's important to go, because we all get this. The person that tells you I've had no complications and have perfect results, they're not being honest about this. And I think you really need that humanism to have that. Now, I'd like to say these complications are just not our monopoly. This is in the New York Times 2 years ago. Patients in Chicago with trigeminal neuralgia, a benign condition, needed radiosurgery. They got a little shot to the trigeminal nerve, minor mistake. They gave 10 times the dosage of radiation. All 6 patients were dead in 6 months. Their brain stems were cooked. So this toxic doubtlessness goes to every field, and we need to be eternally vigilant about it. So what comes at the intersection of toxic doubtless and uncertainty? And I think it's faith and compassion. I think faith, I'm a believer, I would never want to proselytize anybody, but I think that's an important thing, and there's a history of faith in our field. If you look at the Roman Emperor Claudius, the first time the word profession is used, Scribonius is his physician, and he says, a profession is a commitment to compassion or clemency in the relief of suffering. This could be an identical quote from Sai Healthcare, that we want to have this commitment because that is so important. And if you look at any faith, if you look at Krishna when he does a spine operation on the one with kyphosis, or you look at the Western Wall, anybody goes to the Western Wall, it's beautiful. You put a little shit in there, you stick it in, and it's just so soulfully reverberating that it keeps us going. And then if you look at the real Christian tradition of healthcare, I mean, you look at the Catholic hospital in the United States, I mean, this goes to Francis of Assisi, the Benedictine monks, strong history of faith and healthcare. And I think compassion, the Greeks have a wonderful word. There are many forms of love, eros, but agape is the best. Agape is unconditional love. And I think in healthcare, we are really blessed with agape. Ambrose Paré said, je le pensais, Dieu le guérit. I did the dressing, God did the healing. And James Keenan was a Boston theologian, and I love this definition of mercy. And he says, it's entering into the chaos of another. Every day we as healthcare professionals enter into the chaos of others. Our goal is to do it with compassion, to do it with kindness, to do it with a sense of seva. And this is present in art. If you like art, you look at this. This is Goya's self-portrait when he was really sick with cardiac instances. And again, Dr. Desai, I always bring the heart in. So he had a heart attack, and his person took, and he's a wonderful portrait of him taking care. This is Luke Feldis' portrait of a child dying. Luke Feldis' own daughter died. And he was so indebted to the physician that he painted this for them. Issa was the great haiku master from Japan. And he had this wonderful haiku poem, this world of dew is a world of dew, and yet. It's like this is a world of Maya, and yet it bursts. You know, he went through some great personal tragedies. His father died of typhoid, his kids died. But again, that compassion. And I think if you look at the art of medicine, I think the value of medical uncertainty, this is the plan, hoping for plan C. You know, no plan A, plan B. And I think maybe in between toxic doubtlessness and uncertainty, there's the middle path that we search for and hope to do that. I'll diverse a little bit into public health now. So you look at this is John Snow in London, the strict vegetarian, and at that time cholera was thought to be miasma. It's in the air, it's in the air. But he took that doubtlessness away. He looked at all the water pumps in London, and he figured out cholera was coming from the water supply. So again, an innovative thinker, and our debt to Lawrence, I mean, people just think Florence Nightingale stood with a little candle and took care of the British troops. She is the mother of public health. You look at the pie chart, she told you what's happening with these hospitals, why people are sick, what's going on. And again, a great luminary in that field. But we as a profession need to look at ourselves critically. Toxic doubtlessness was shattered. When the Institute of Medicine report came out, there's 100,000 people dying every year because of medical mistakes. Just to give you perspective, that's like 4 747s crashing every week in the United States. Every week. That's huge. And we take responsibility. Wrong medications, wrong side surgery, these things happen. So, it's not going to happen to us. So this is an example in Tenerife where a KLM flight was about to take off. Okay, this is on the land, all right? He has co-pilots, they're ready to take off. And they say, okay, you know, we want to check with the control tower. He says, no, he doesn't check. The pilots say, well, we should keep quiet. The 747 crashes on the land with a TWA flight, 573 people died there. Again, I think from an Indian cultural background, we believe in the hierarchy of power sometimes too much. You know, if you're the big professor and the nurse comes in and says, you're operating on the wrong side, you should listen to that. You shouldn't just think, oh my God, I'm too big. How could you question me? I remember it was a young attending. I was taking a tumor out, and the intern comes up to me and says, Dharnendra, you know, this tumor's on the right side in the brain stem. I'm like, how are you going to get this from the left side? I'd made the incision. I'm like, okay, close it up, talk to the family, switch it around, got it done. This happens to us, and we have to be extremely careful. The safety in the aviation industry did a beautiful job on this. You can see the number of crashes have gone down. You don't think twice before going on a plane right now. Your chances of getting injured in a car accident are much more than when you fly. And that's because the pilots have been very good about that. And this is what the press does. I mean, you look at this is toxic doubtlessness. This is from the Wall Street Journal. They say every hospital in America has a Dr. Hodad. Like, who's Dr. Hodad? It's hands of death and destruction. I hate to tell you this happens everywhere, and we as a guild protect each other too much. We don't say, oh my God, maybe we need to report this, maybe this is not right. And I think the Swiss cheese model is so true, it goes right through. I show this slide to my residents frequently, that you make mistakes. You're like, if you don't have filters to prevent this, it's not gonna get better. And this is the Mass General, very world-reputed orthopedic surgeon, does a mea culpa editorial in the New England Journal of Medicine where he operated on the wrong hand. How does that happen? In the world's best hospital by every survey, US World News Report, whatever, you're operating on the wrong side. So this stuff happens, you have to be vigilant about it, and this comes from toxic doubtlessness, like hubris. How could I make a mistake? I'm not moral. And I think that's what we need to be really good. These are the 10 shocking medical mistakes. You look wrong side surgery. And this is a kid in New York that was, he had an oxygen canister with him, went straight right through his head, and he died on the spot. So these are errors that happen that we have to be eternally vigilant in and again, generals talk about making decisions in the fog of war, and we practice medicine in the fog of war, fog of medicine. Sometimes there's no clear-cut answers. Most times we know what we're doing. Sometimes we don't. But that openness is extremely important. And I think public health-wise, they talk very well about diabetes, Dr. Mohan did yesterday. Look at obesity. Obesity is a huge problem. And you talk about cognitive dissonance. We had a brilliant lecture on diabetes yesterday. What did we all eat when we went out there? Who's not guilty of eating a cookie? We got to address that, right? It's cognitive dissonance. Like, oh my God, where did we miss? This is obesity in 1985, United States, 1995. And then the chart, there's new colors coming up because the BMI is going over 30. So this is a big problem. And I think, no matter what your specialty is, you have to have a devotion to it. I will not operate on patients that smoke for spinal fusion. I refuse to do it. I said, unless you show me the determination that you're going to quit smoking, I'm not doing a $100,000 operation on you. I just think it's morally reckless. I'm like, no, we're going to check your nicotine level. You can't quit. You got to show, you have to show commitment. And same thing with obesity. Here it is, huge things, and this is a global problem. And I think the mismatch is where Sai healthcare comes in a lot. Mexico has now overtaken United States as the most obese country. And this is David's Michelangelo in today's case would be a little different. And this just shows you the chart of physicians working. You can see sub-Saharan Africa, we don't have enough physicians there. Maybe and this is the wonderful outreach programs you guys have talked about. And then you look at stroke deaths. I mean, India and China, huge stroke deaths. Again, diabetes. Again, this is where we need to create awareness. And again, costing. You want to make free. This in the United States, geography is destiny, okay? If you go to Florida with your back, you're 4 times more likely to get an operation than if you're in New York. Just the way it is. Even in McAllen, Texas, you get a cardiac cath, you'll get a scope done, you'll get all this done. So there's these immense vagaries on this, and it's not based on hard science. And I think this is Porter's work on quality and service. This is very important, that we give ideal health care that means good quality, good service, but it has to cost less. We can't just say everybody gets a Cadillac. Maybe you all need to take the bus. The bus might get all of us safely there. And I think in our own specialty, spine has had an explosion. We now spend in the United States over $90 billion on spine health care, more than cancer, okay? So you would think you spend all this money, your outcomes are much better. Everybody is like doing yoga at 90, they're looking great. No difference in outcomes. So we're spending all this money and we're not getting a good result on that. And then sometimes we can overkill. So in South Korea, they had this whole program to diagnose thyroid cancer. Everybody got an ultrasound, okay? 15-fold increase in thyroid cancer surgery in South Korea. You would say, great, this happened. Now our mortality from thyroid cancer will go down. Guess what? There's no difference. So we were doing all these unnecessary operations on them. This was affluenza all over again. We're going to give you a test. We're going to do all this stuff. But by the way, you probably don't need it. So that's not good either. My own area that I'm very interested in, concussions. You know, perhaps in this audience, sports is not that important. India doesn't do too well in the Olympics when it comes to athletics. Every Indian kid goes to the spelling bee. He ain't going to football camp, okay? It's just the way it is, guys. It's a cultural thing. Just get used to it. So this is just, we talk about, can you play this here? So here, this is just to show you some of the videos. These are the kind of concussions we see. You know, I feel bad with this McGregor fight. You know, it's like massive concussions. These people have bad issues. We've seen some of the NFL players, and these are bad, bad injuries, yeah. And look at this, somebody going to Grand Mall, the rugby match right there. And here's another one, look at the head-on collision right there. So again, we need to create, and this has become important for PTSD, the troops coming back from Iraq, you know, used to, oh, there's nothing wrong with you, get back to work. You know, this was doubtlessness in the 70s after the Vietnam War. We didn't recognize PTSD, like, doesn't exist. Your CAT scan's normal, you just don't want to work. So I think that, again, is important. And I think we should also look at this from a governmental and political activism point of view. So I always call nonviolence, you think, you know, sort of a Gandhi thing, it really starts in the United States. I call this the American boomerang, because Thoreau first talks about civil disobedience. It's taken up by Tolstoy. Tolstoy loves that, and then Gandhi gets very influenced. I was just in South Africa, and I visited where Gandhi was, and he named his farm the Tolstoy Farm. And if you look at that, that influenced Martin Luther King. And so he does this whole injustice anywhere is injustice everywhere. And I think it's so poignant today that, you know, all this influenced Madiba. Nelson Mandela, if you ever have one thing to do, you should visit Robben Island. Here's a man who spent 27 years in one cell because he believed in a cause. It's very poignant to see that. And I thought this was so powerful right after the Charlottesville incident. President Obama's tweet is the most tweeted tweet in history, 2.5 million retweets. And all he does, he doesn't say anything, he just quotes Mandela. He says, no one is born hating another person because of the color of his skin or his background or his religion. People must learn to hate, and if they can learn to hate, they can be taught to love. For love comes more naturally to the human heart than its opposite. And I think this is wonderful, it's great. But you got to remember, sometimes love doesn't work either. And you know, one of the great things about Gandhi was he actually wrote to Hitler and said, you know, 19th dear, I would like you to desist this, you know, you should be nonviolent. Some of these people don't listen. Hitler's solution to the Indian problem was you kill Gandhi and then you kill the next 100 Gandhis that come up. So sometimes our puritanism doesn't work. And I think our political activism is important. You know, if you look at the Burton institution, the Hill-Burton Act built $5 billion worth of hospitals in the United States. And especially if you're from the South, they were segregated hospitals. It's just the way it was. They're like, okay, we're getting federal money. Well, after the civil rights movement, they come in and they say, you do not get aid if you have a segregated hospital. Overnight, hospitals get desegregated. You know, so what impact does that have on healthcare? Well, it's clear cut. If you look at the number of births, African-American births in hospitals, after 1965, it catches up in about 5 years. The other thing is, you look at postnatal infant mortality deaths due to diarrhea and pneumonia drops precipitously. So government intervention does make a difference, and we know this from historical facts here. That's why this is important, and we should be, you know, involved with that. So to sort of time it all up, I think we have to do no harm. I think we must be honest. These are Rembrandt's self-portraits. If you look at him, he paints himself with such honesty. It's not like he puts a facelift of himself, like, puts a little Botox on myself, I gotta look cool. No. This is how we as physicians need to look at ourselves. Just be honest, what are we doing? So toxic doubtlessness is from Mars, uncertainty is from Venus. And half of what we teach you is wrong. I always tell med students, we just don't know which half. You know, we hope to get you right, but I think we have to be honest to know that. And so I will leave you with equanimitas, the great concept in the 1890 graduation address that Osler said. You know, Osler was an amazing man. So he went as Regius Professor at Oxford, and 40 years later, some woman comes up to him, weren't you a professor at Toronto? He said, yes. He says, 40 years ago, my brother died there. You took care of him. And he said, no parent should go through that, but you took the time. He was in Toronto. He sent a letter to England to his parents and said, your son died a noble death. I read him from his favorite scriptures, and he died peacefully. No parent should go through the death of their child, but this letter meant the world to him. And I think that is the concept of compassion that matters. And I think Francis Collin put it best. He was in Africa, and he meets this patient with pericardial effusion, and he doesn't know what to do, and he puts a needle in, and the guy's like disconsolate. And the guy looks at him, he says, you have some doubts why you came here? He said, yeah. He said, you came here for one reason. You came here to help me. And I think that's what we all linked up for. We're here for a reason. And I would end, as always, that, for me, and I address this to the younger people, the greatest privilege of my life was to be impacted by Bhagwan. It was in my chromosomes. Nothing I have ever done would ever give credit to how much he gave to me. And I would take me several lives to give back. And so I was incredibly blessed. And I think we all need to have that. We need to have that common devotion, that common calling, that it's a great privilege to practice this great art. And we are so blessed to do it. Sai Ram, thank you.
Thank you, Dr. Nanda. By the way, God is Hridayavasi, not Brainvasi. God is a resident of the heart, not the brain. So one of the slides from yesterday, one of my favorite slides was Dr. Panchanathan's slide, where she talked about work, service, and fun. And I think Dr. Nanda genuinely has fun doing what he does, and another excellent example of that is Dr. Narasimhan. I have rarely met somebody as passionate doing what they do. Dr. Meera Narasimhan is incredibly accomplished. She is chairman and professor of neuropsychiatry at the University of South Carolina. She is associate provost of health sciences at the University of South Carolina. Please welcome Dr. Narasimhan.
Sai Ram to my Sai family. And it's a daunting task to follow a neurosurgeon, but at least we are in the same organ system here. It's truly a blessing, His infinite grace and love, to be able to have this opportunity to present in front of such an august group of healthcare providers from all across the globe about my passion for mental health, kind of the spirit of service and devotion that Swami kind of, gets us all into, in terms of trying to, in the context of Sai ideal healthcare. So hopefully, by the end of this talk, unlike the Egyptians that you mentioned, Swami will allow me to make a case for the importance of the human brain, its connectivity to the heart and the rest of the organ systems. Here are my disclosures. So what I'll do throughout this talk is try to kind of look at what we in modern medicine understand through science about disease, health, and wellness, and what the pearls of wisdom that Swami has laid out in terms of his teachings, in terms of the way that he has led by example, and how do we make sense of it all as we try to provide to the world the ideal healthcare. So if you look at the World Health Organization, we've kind of looked at this particular slide that many of our presenters presented over the last day or two. But what is important is to pay attention to, when we talk about health in the context of mental health, it's not just the lack of disease or infirmity, it's mental well-being that the World Health Organization talks about. And so it's just not talking about mental disorders, infirmity, disability, but much, much beyond that. And that's where kind of Swami's teachings truly help us in being able to look at it more from kind of, what does Sai ideal health need to look at? So when Swami talks about universal healthcare, provision of healthcare across the board, how do we start to break silos that do exist in our current healthcare system? Very often we focus on our particular specialty or organ systems. And again, I know it's worldwide, especially in the United States, as we are trying to look at kind of our healthcare systems, how do we work more towards interdisciplinary, multidisciplinary teams in trying to address some of these issues as a whole for our patients? Of course, provision of free healthcare, and I'll give you an example towards the very end, talking about how do we start to make some of what Swami has already led by example, making it feasible through our super specialty hospital medical camps that he has been able to kind of, run through various devotees, to be able to translate that into action. Of course, humanism in medicine is an important element that we all need to focus on, and we have started incorporating a lot of that into some of what we talked about in the medical education and curriculum already. And I think it's also about kind of how do we bring about compassion, love, respect for one another, also about kind of serving with dignity in terms of how do we make sure that the patient is well cared for, putting yourself in their shoe. My focus for this talk will be on comprehensive healthcare, trying to look at the mind-body-spirit connectivity, and I think that's extremely important. I hope I'll be able to make a case for that by the end of this presentation. And of course, preventive health, which I think is extremely important, not just in the sense of maintaining health once we have treated the disease, but also in terms of mental health literacy. How do we go on to address and increase public awareness among individuals that we end up treating about the stigma that exists, clearly when it comes to addressing mental health problems? And of course, provision of immediate health care at the doorstep of our patients who are in distress, using love and compassion, using technologies. So the Eastern philosophy has paid a great deal of attention to the mind, body, spirit connect. So they're all interconnected, these pillars. But again, when they are out of sync, they are in disequilibrium, that's when you have dis-ease, not being at ease. And again, as healthcare providers, I think we've not done a very good job in terms of trying to understand this connect and about kind of working together along with the spirituality component of it, alternative complementary medicine. I think there's a lot, the movement has begun, and Swami truly has showed us the way to be able to bring it all together as we start to kind of, make these connections to be able to deliver ideal health care. Swami often talks about mental purity in the three gunas, sattva, rajas, and tamas. So when you talk about this, he also talks about mental purity and its relatedness to food purity. And when we talk about food, it's not food in the strictest of sense, not what we ingest. It is what the feeds that we end up getting through our panchendriyas, the five senses. What do we hear? Things that are unpleasant that we end up hearing, or something traumatic that we end up seeing on the television or witnessing. Olfactory kind of perceptions, tactile perceptions, gustatory perceptions. So all of these do play a role in how we process information, which then results in kind of it affecting our mental and physical well-being, so to speak. How do we understand it from a modern science perspective? We often talk about the gene-environment interaction, right? So you have environmental factors, toxins, for example, or kind of the environment in which they were raised, stressors in one's life, stressful life events. How does that gene-environment interaction result in culmination of disease? So most of what we see today is as a consequence of this are lifestyle diseases. So if you look at Darwin's theory of evolution today, we are becoming a fat, dyslipidemic, diabetic, depressed society. So to me, no matter which illness you pick from this slide, diabetes, heart disease, cancer, depression, anxiety, all of these are on the rise across the globe. And there is a great deal of interconnectedness between these illnesses, whether we talk about kind of physical illnesses or mental illnesses. Let me kind of give you a sense of what is the scope of the problem that we are trying to address. Across the globe, 1 in 4 individuals do experience a mental illness in a given year. Those are staggering numbers. 330 million individuals all across the globe suffer from depression. 10 million suicidal attempts across the globe, with about 900,000 suicide completions in a given year. It's one life too many to be lost. And hence, we really need to start to address this together collectively as humans. Now, the World Health Organization, we were talking yesterday about communicable, non-communicable disease, with the rise in non-communicable diseases. If you look at the Western world, depression already is the second leading public health concern. But by 2030, look at what happens. It surpasses heart disease. So to me, each one of you here, irrespective of what your specialty is, need to be in a position to effectively screen patients for depression, to be able to treat that, because it clearly has a bearing on other bodily functions. When one looks at mental illnesses, and this slide clearly goes on to demonstrate affective disorders, the prevalence of physical illness in those with affective disorders. Whether you look at depression is a great example. Depression, cardiovascular disease, right? Post-MI, the rates are anywhere from 25 to 50%. Cancer and depression, very strong links. If you look at Parkinson's disease and depression, I can kind of keep naming. Diabetes, about 27% of individuals, the rates of prevalence. Hypothyroidism, you name it. It's kind of across the board. And I think we really need to be prudent in how we go on to render clinical care as we start to look at an individual as a whole, because each of these has a detriment. If you don't treat the depression, how are they going to be compliant with a diabetes regimen? So I think it's important to be able to focus on some of that moving forward. If you look at the standardized mortality ratios for those with unipolar and bipolar depression, it's about 2-fold higher compared to the general population. And this is predominantly due to endocrine disorders, cerebrovascular and cardiovascular disorders. Patient with schizophrenia has a 2-fold increased risk for dyslipidemias, a 2-fold increased risk for diabetes, 2-fold increased risk for hypertension, 3-fold increased risk for smoking. So if you have all of these risks, their cardiovascular morbidity mortality risk goes up anywhere from 10 to 14 times, and hence a shorter life expectancy. So let me try to use depression and cardiovascular disease as a prototype to kind of impress upon you the need for this mind-body-spirit connectivity. There are increased rates of depression in those with ischemic heart disease. Depression is a risk factor for morbidity mortality post-MI. Now, there have been studies which have gone on to demonstrate that if you were depressed, and they follow this cohort for about 4 years, and they found out that they were at a higher risk for coronary artery disease. So there is a bidirectional relationship between the two. What came first, the chicken or the egg? Depression is also associated with increased platelet activation, platelet reactivity. So very often when I joke with my cardiology colleagues, I often tell them, you treat heartache, I treat heartbreak, we need to work together. Swami often talks about hurry, worry, and curry, right? So that has implications in cardiovascular disease, but it also has implications in mental illness. So here is a wonderful kind of example of that. So to me, as a neuroscientist, where is the evidence? Show me the evidence. And here is, you're looking at the HPA axis. So constantly being bombarded by stressful life events activates the hypothalamus, which secretes corticotrophin-releasing factor, which acts on the pituitary gland to release ACTH. ACTH then acts on the adrenal gland to release cortisol and catecholamines. Now, this has bearing not only on depression and PTSD, but also has bearing on atherosclerotic lesions, ventricular arrhythmias, myocardial ischemia. So what you see here is a story developing in how one affects the other. And I think that's important for us to understand as we start to look at treatment interventions, of course, being more of a holistic approach to treating these illnesses. So one might ask, what is really treatments? What do they do for depression? And when you look at treatments for depression, so we know that in folks with depression, given what we just talked about, the neuroendocrine, the neurobiological implications, you have significant loss of neurons. People have memory problems like loss of neurons within the hippocampus, which results in that. So with treatment, so you have neuronal loss in certain regions of the brain. With treatment, be it antidepressants, be it psychotherapy, be it spirituality in the form of meditation, exercise, all of these do go on to not just kind of increase neurotransmitters at the cell surface, dampen the neuroendocrine response that we see, but they also have some downstream effects in terms of second, third, and fourth messenger systems, increasing neurogenesis. When you do exercise, you feel good because you have an increase in vascular endothelial growth factor, VEGF. VEGF then triggers BDNF, which is brain-derived neurotrophic factor. And all of this then results in gene transcriptional changes. When you have gene transcriptional changes taking place, that in turn results in disease modification. Disease modification results in alleviation of symptoms of depression. So again, what you really are looking at is no matter which illness you kind of touch upon, with these treatment interventions, with spirituality being a core component of it, it truly helps in regenerating neurons. Who would have thought, 50 years ago, the brain had the ability to regenerate? And there has been sufficient evidence which clearly goes on to demonstrate that. So I think today's clinical practice, it would be prudent for us to start to work together as we start to look at Sai Ideal Healthcare in being able to kind of look at this mind, body, spirit integrative approaches to treatment, wherein a spiritual counselor needs to be a core part and parcel of treatment interventions that we render. Let me now shift gears and talk a little bit about preventative care. And when we talk about preventative care, I think despite all the progress that we have made in the 21st century in understanding the neurobiological underpinnings of mental illnesses, as well as an extensive armamentarium of medications, we have more than 30 antidepressants that are out there that are available, yet we continue to grapple with stigma. So to me, how do we destigmatize mental illnesses? And to me, the first step is in terms of literacy, mental health literacy. How do we educate one another, providers? How do we make people more aware of this is a brain disorder which clearly needs to be treated and addressed. In addition, once the patient gets to be well, what is it that we need to focus on? Here is a prescription for resilience. So focusing on positive attitude, having a good role model is very important. Cognitive flexibility, having a moral compass which truly focuses on core beliefs, faith, altruism. And a lot of that is taught within the Sai family. And Swami has truly led the way in teaching us a lot about this, coping skills that truly help us in terms of improving our resilience for reducing vulnerability. And of course, all of this ties into physical well-being. I'm going to focus the next few minutes on trying to look at how do we innovate to integrate. Now, the Lord has endowed human beings with intellect. To me, how do you start to think outside the box and being creative? And it's only when you have challenges that you also start to look at how do we go about addressing it, and the opportunities emerge. And that, to me, truly has been something that Sai has taught us along the way. We were faced with a situation in the late 2000s, wherein we had, with the economic recession, the Department of Mental Health, which runs the state hospitals. So we had, because of economic restraint, we had to cut down the number of beds within state hospitals. And as a consequence, a number of these patients ended up going to the emergency rooms. So there was a significant outcry by folks within CEOs of hospital systems. How do we go about addressing this? And that's what resulted in out-of-box thinking in trying to bring people together. The public sector, the private sector. South Carolina has about 64 hospitals in our state, and then academia. We work together in trying to look at technology, telehealth, as a means of delivering care within the emergency rooms in the state of South Carolina. We were also fortunate enough to have the National Institutes of Health, and more recently PCORI, which is the Patient-Centered Outcomes Research Institute, be able to fund us to look at scientifically and systematically measuring these outcomes. So we've seen about 35,000 patients across the board over the last several years, and some of them clearly are indigent, which fits into the the free care that is a part of Sai Healthcare here. universal care, parity for mental health being provided, compassionate care, and there have been numerous instances wherein patients really have that therapeutic alliance, that connectivity with the patient, despite the fact that they are separated by distance as well as by a screen that separates the two. And of course, all of this has resulted in us being able to demonstrate shorter lengths of stay within the hospital systems, threefold increase follow-up rates out in the community, which I think is important. How do you not make them come back to the hospitals? And then, of course, the cost savings. It's about $1,800 cost saving per patient, with about 35,000 patients already being seen. Enormous cost savings for the state. We've been able to kind of get stakeholders from across the board to be able to be a part of this project. And this includes payers, because it is important for us as we are trying to look at provision of healthcare for the uninsured indigent. We also need to have kind of, the payers, the insurers be a part of this. So it's just been a phenomenal experience to take it from there and scale it to other specialties, not just in psychiatry. We have it in OBGYN, pediatrics, ID, infectious disease, hepatitis C, HIV. So to me, it was also important for us to be able to not just from rural South Carolina, how do we then take it to India? Very fortunate to have a dear colleague of mine based out of Tamil Nadu, from Madurai, who clearly has been a champion. So we ended up getting Hewlett Packard as a part of their corporate social responsibility to work with us and providing us a mobile van to kind of go through rural counties in villages in India. And just to give you a sense of the disproportion of kind of providers to patient ratio, in the United States, in the state of South Carolina, it's about 10 to 12 per 100,000 psychiatrists. In India, it's 6,000 psychiatrists for a little over 1 billion lives. Just talk about how do we go about addressing this problem, which World Health Organization says we are the second leading public health concern. Depression is the second leading public health concern. How do we go about doing it? We really have to be creative. And that's what Swami talks about in terms of, clearly he's endowed us with this intellect to be able to be creative. And there are no limits. We've been able to incorporate ultrasounds, V-scans. Kind of, you can have somebody who is trained in V-scan in rural counties. You could have a pediatric cardiologist kind of listening in on our side to be able to make some of this and translate that into action. So it's just been incredible service being done by our colleagues in Tamil Nadu, in the Ramanathapuram district. They see about 250 patients per month, and they've been doing it since 2013. So truly, Swami has opened vistas to us in terms of the way in which we connect with people, the way in which we can bring people together, various stakeholders, and how do we work towards a common goal. Alone we can do little, together we can do much. And I think it's kind of, we've been able to bridge policy, practice, and research through all of this. So when we talk about kind of Sai ideal healthcare, Swami's the 5 principles have truly redefined modern healthcare as such. Swami has led by example. If you look at the various initiatives, Educare, educating people about health issues, that connects to Medicare, which we just talked about, the ideal healthcare, which then has implications on social care. This is a great slide, which clearly gives you an analogy of the health and well-being of a human being to the health and well-being of our society. If the cells are in harmony, they constitute an organ being in harmony, organ systems being in harmony, kind of the body functions well. And if you look at an individual in harmony, these individuals can be productive kind of, contributors to the community, which then the community gets to be in harmony, which then translates into the society being in harmony. And these are immense pearls of wisdom that Swami has truly taught us. I'll end with this last slide. Clearly, we heard this beautiful rendition of Neelamegha Shyamala this morning. Sai Krishna in the Dwapara Yuga was the greatest psychotherapist counselor and who has taught us the Bhagavad Gita. In the Kali Yuga, Sai Krishna, or Swami, has truly been able to kind of lead by example. He has taught us to serve with love. He has taught us with love, man is God. And he has truly been a beacon who has continued to inspire us to be better and hopefully someday ideal human beings, within the healthcare realm to be ideal providers, at some points in our lives, ideal patients, to be able to kind of work towards this legacy of ideal healthcare. Om Shri Sai Ram. Thanks.
Thank you, Dr. Narasimhan. So it turns out there is a bridge between heartache and heartbreak. There is small but limited data to suggest a mortality benefit from meditation that rivals ACE inhibitors, statins, the best tools that we have. To further talk about this, I'd like to introduce Dr. Brahma Sharma, Associate Professor at UPMC.
Sai Ram, I have been overblown by this high-flowing ideas from Dr. Nanda, Mayur. Since all of you have been talking about the heart, maybe I should change the gear, and I should talk about the brain. So in this hyper-connected world, where we are trying to get connected to everybody all the time, what is happening is that we are getting disconnected from ourselves. In trying to get in touch with everybody, what is happening paradoxically or ironically is that we are getting out of touch with ourselves. And that is the saddest irony of our times. We are living in very turbulent times. And when you live in these times, that kind of dichotomy and irony, this is what happens to us. So this is the state of our mind. You may call it whatever you may, spiritual distress, existential crisis, or a burnout. So this is something people have also called age of anxiety, or maybe an age of Trump. Now the problem is, why do we suffer like this? And over the centuries, the question is not new. Actually, the question is old. And about 2,600 years ago, another young prince was also contemplating the answer to this suffering under a fig tree. It took about 42 days, and he came up with some noble truths and some path, or marga. And the marga is meditation. I know it sounds like new age stuff, but meditation is the only rescue to bail us out from this mental insanity and to restore our sanity of our mind. Now, meditation is not unique. Now, we Indians from Hinduism want to claim that this is our patented thought, but meditation actually is a universal principle. If you look at the books by Andrew Newberg, he's probably the foremost authority on meditation. And he writes that meditation is actually a universal principle. In all the great traditions, Christianity, Jews, Judaism, meditation has been mentioned. And actually with the Dalai Lama and the neuroscience, there's a new science is developing called a contemplative science, neurotheology, neurodharma, and neuroenlightenment. So this is not a fad, this is the science coming back. And because of that, there's a lot of interest in modern science, and that is where I got attracted to this meditation, not only as a faith, but as a science, as a real science that can show us a roadmap to restore our sanity. Now the history of science, or history of meditation. Now in Vedic age, about 5,000 years ago, people were sitting under banyan tree and looking at the fire. But the historians kind of dismissed that experience as some kind of a pot smoking, all these hallucinating Babas and gurus of the yesterday India. But when Dalai Lama and when Buddha came, it gave some authenticity, but again died down. Nobody paid attention until Vivekananda came to America almost 100 years ago, and people started looking back at the meditation, but there was no science. It was, again, something very esoteric, occult, limited to a few people who had no background, and was kind of brushed aside. Dalai Lama came to the forefront, and he became one of the 4 figures in the neuroscience. I don't know how many you know. I know Anil Nanda and Venkat knows that he was one of the guests in one of the neuroscience conference. He invited a lot of neuroscientists and researchers to Dharamshala. He conducted the new science where Eastern wisdom and the Western neuroscience connecting together. And that has taken over this new field of neurodharma. Of course, Mahesh Yogi, the transcendental meditation, and the Beatles kind of popularized this. And of course, the duo combination, the very powerful duo of Oprah and Chopra kind of commercialized it. But the one person that actually deserves the credit the most for bringing meditation from the occult to the regular mainstream, from mystical and metaphysical traditions to the medical science as a mainstream, is this last guy, John Kabat-Zinn in Massachusetts. He is the one guy who has actually brought the meditation into simple mindfulness and has taken to the Google chat rooms, to the armies, to the sanitations, to the prison houses, to the medical schools. And from there on, the meditation has become so mind-boggling as a common phenomena that many people call it mindfulness. It becomes like McDonald's, a common commodity, commercialized. So there are many types of meditations, and I know we don't have time to go into those, but fundamentally meditation is the same thing. Basically, meditation means, according to the Greek definition, centering the mind, concentration, and then relaxation of the mind to a particular thing. An object could be a song, could be a bhajan, could be namasmaranam, could be chanting. Anything can happen, but on the brain level, we'll come to that later, at a neurocircuitry, a neural pathways, bottom line is the same. And out of these 10 different types of meditations, I'm going to just talk about maybe one or two. The most popular, of course, in the history was Vipassana, originally from Buddha, and that is a powerful means of self-transformation by self-observation, Vipassana. But now, in a vogue, we have two types of meditation. Of course, the mindful meditation, and the new variety of meditation that has been used very powerfully now is a compassion meditation called a metta meditation. And when we talk about mindful MD and mindful care, the metta meditation is the one that has been showing more promise and more force behind it. Metta meditation is a compassion meditation, loving kindness meditation that has been shown more data. So, how the meditation has become mindfulness because of John Kabat-Zinn. And the very basic, simple definition is meditation is be here now, in the moment. And if you want to read the definition, it's paying attention in the present, on purpose, without judgment. Wherever you are, however you are, you just be in the moment and pay attention and let the thoughts come by. The thoughts will come and distract you, but let them go like the clouds in the sky. But be in the moment. That very practice of meditation is the one that is promoting, which is very secular, very scientific, and also mainstream. You don't have to go to a guru or a Himalayan caves and have a candle or an incense or a Lululemon pants. You can do it anywhere, wherever you are, whatever you're doing, just 2 minutes, 3 minutes, 5 minutes, 10 minutes. But practice requires the meditation to be successful, and this is the kind of meditation and the neuroscience I'm going to talk briefly. Now, this is the world's happiest man. I don't know how many you have read his books. He's Matthew Ricard. He is actually a molecular biologist who gave up medicine and went to become a Tibetan monk. And when the people from Wisconsin, Richard Davidson, tried to study his brain, they found that he was perhaps the happiest man in the world, because when they put the functional MRI is the MRI that can actually record the metabolism of your brain. They found his left frontal lobe, which is the site of compassion, gave so much energy, so much light, that they had never seen this. So not only on the EEG, but on the MRI machine, they were so surprised to see this a light glow. And this is because overactivation of the left frontal lobe, which is seat of compassion. He's Mr. Compassion. He's the one who's promoting this compassion meditation or metta meditation. Now, a little bit of neuroanatomy, because Brother Anil and Brother Mayur and, we're talking about too much about the heart. Let me talk about the brain. Now, the brain has different, evolutionary wisdom. We think about evolution as some kind of freak accident. No, there is wisdom in every step of evolution. The way we survive, why we survived, there is always a message and signatures in the evolution. The brain has three components. First is the reptilian brain, which is very, very instinctual brain, and then the feeling brain, the mammalian brain. But the brain that is in the forefront, the neocortex, which is 76%, is the thinking brain. And the reason I'm talking about these things is because this is how the dichotomy takes place. The constant conflict between the thinking and the feeling, the emotion and the reasoning. And we always get into trouble because of this disharmony or disease that Sister Meera was talking about. So we have become a thinking human being, but it's still because of constant conflict, we develop that stress and distress. And again, this thinking brain is the forehead, and the feeling brain, emotional brain, is the hind brain. And because of back and forth, there is a constant dialogue going on and tug of war, and that causes all kind of imbalance and distress between internal and external, and we develop the stress, anxiety, and the suffering. Not only that, in the brain, there are 2 points of brain here, the right brain and the left brain. The left brain is very mathematical, nerdy type, very calculating, analytical, but the right brain that we need to develop is intuition, innovation, inspiration, and creativity. So there has to balance between these 2 parts of the brain and also between the brain, the hindbrain, and the forebrain. Now, as a scientist and a physician in us want to know how this all happened, how did it survive? And rather than going to the belief systems, I thought I'll talk to the science behind this. The first person who took the chart on our response to stress was Walter Cannon at Harvard. In 1920, he studied what we call the fight and the flight response. Now, this fight and flight response was present in our forefathers millions of years ago, because when we were walking on the beaches of Serengeti Plains in Africa, and the saber-toothed tigers were chasing us, this was the only thing. You are looking for the food, either you get the food or you become the food. But the problem was that this acute response was very helpful for our survival in that time. But problem today is that this acute response has become chronic. We are constantly being demonized, and something is chasing us all the time. We are persecuted by this stress phenomenon all the time. And that's why it becomes a chronic response, and that's very detrimental. The acute response, which was good for survival, which was saving us, now the same response has become a perpetual response, a chronic response, leading to chronic inflammation, chronic disease, and is killing us. And so this response is a maladaptive response. The second person who took a shot at this, again from the Harvard, Herbert Benson, I know some sisters and brothers were talking about yesterday. He actually was not very keen to study the people, but meditation, transcendental meditation, was very popular in the 60s in the hippie cult area. And some of the students from the transcendental meditation of Maharishi went to him, and he said, no, I don't want to study you. Nonetheless, he put them under scope, and he found out that there is a physiological response of meditation for the first time documented in the lab in the Harvard. And of course, we'll know about that, the decrease in the blood pressure, decrease in the heart rate, and decrease in all those things, and temperature also. And this response, he wrote in the book, and the book became the bestseller book, Relaxation Response. But the response that the neurotheologists or neurodharma people, the dharma people like Dalai Lama and all these neuroscientists of the new age are saying that there's another response. And that response is a mindful response. Means any situation, you don't freak out, you don't fight, you just accept. You accept the way it is. You don't react, you just respond. And we don't know the neural pathway for this. People are figuring out where this all happened. But they think this is the best response for our common age, and this is the response that Buddha taught, that accept what it is. Go with the flow, be in the moment. Don't fight it, just be in it and uplift the moment, because you're not going to change. Because we are not really a body phenomenon, we are a spiritual phenomenon. We are spiritual beings living in a human existence. So you do what you can do, but get with the flow, don't fight it. So initially, the people only had EEG, and they studied all these brain waves, and I don't have time to go into this, but the more you meditate, from a gamma to the beta wave to the alpha to theta, slows down. You can see on the left side that slows down, and in between these gaps, there is a moment of space or a sacred silence, what we call the people who read meditation practice. That sacred silence is nothing scientific. Nobody knows. Nobody can explain that. But if you go to metaphysics and mystical training, that silence is the source of intuition and innovation and thinking and connectivity and creativity. So that I cannot decipher scientifically, but that phenomenon is the one that is source of all the mystical phenomenon that you get. And the next thing is a functional MRI, which is a very scientific thing. And then the next one is the default brain. The brain that is in default mode that we all the time thinking about is a default mode, and the meditation or mindfulness of being for default to the focus mode. They found this neural pathway, why we suffer, why we ruminate, is because of default mode. And of course, they have laid down the pathway, the neural pathways of the meditation from the frontal cortex to parietal cortex, all the way to thalamus to hypothalamus, and ultimately to the hippocampus, where you get a glow, an arousal, and a bliss. And when you go back and forth, it is actually balanced between sympathetic and parasympathetic nervous system, and that will develop equanimity. Now, this is the meditation on the brain. And Sister Mira was talking about neuroplasticity. That is a phenomenal discovery that our brain cells are not dead. Actually, we can regenerate, and you can develop new wiring and new synapses, and that is a profound contribution of the meditation and mindfulness that we didn't know, but it's now medically shown that you can rewire your brain, you can lay down the neural pathways, you can sculpt your brain again, you can reduce amygdala, you can do neurosurgery without a scalpel. So this is the phenomena that I think we focus. This is a very powerful, this is a very empowering idea behind meditation, that you can remind your brain. We all know that the brain will control your thoughts, but can the thoughts control your brain? This was not new. This is something very phenomenally profound, disruptive, that yes, you can control your brain. You can make your brain by having good thoughts. Good thoughts will lay down the pathway for a good brain. So vice versa is also true. Now, this is the most important study. I have so many studies, but because of lack of time, let me show you this. Salazar from Harvard, and she showed that by meditation, only about 10, 20 minutes, you can increase the cortical thickness. And cortical thickness is very crucial. It improves our memory, our speed of thinking, and delays dementia. So this is something you can do every day, 20 minutes, even 8 weeks, it showed the change. And then, of course, the next study is next one is this area of the second set of pictures in your temporal lobe and the parietal lobe, where you have empathy and compassion. And the last one is the amygdala. Amygdala is the brain center where you have all the freak response, the fear monger, the fear center. And by repetitive meditation, they have shown that you can shrink the amygdala and you can calm your brain, increase empathy, increase compassion. So this is emotional regulation by meditation. And this is much better, much more long-lasting than the antidepressants. Now, this is a cardiology. Only two things I will mention briefly is this important journal, Journal of American Cardiology and Circulation. You can see that a lot of studies have shown the rhythm control, the atrial fibrillation. There's a study called Yoga My Heart. It has been shown more than the medication, mindful meditation, yoga can control your AFib and prevent relapse and recurrences. And of course, this is a study that Gopi was talking about, circulation, that in addition to lifestyle and other risk factor modification, mindful meditation in Afro-Americans and other population have shown 43% reduction in mortality. That is something very profound. You don't see many journals and articles talking about mortality reduction in 48%. Now, this meditation on the telomere, it delays your aging. These chromosomes at the tip that are frying and being fossilized, meditation will rewire them and also increase the content of telomerase and will keep you going. So it will provide the anti-aging effect. This is the most profound study in the Stanford Center of Compassion where they show that meditation not only changes your brain, your heart, but it can change the very genome. It can change the genome at the DNA level, at a cellular level, by all this oxidative pathways, nitric oxide, oxytocin, and all these good hormones and good cellular markers, decrease cytokines, decrease interleukins, and nuclear kappa beta factor that is a source of inflammation and genetic expression. And this is the epigenetics I was talking to yesterday with Sister Meera, that meditation, epigenetic human genome, which is kind of done deal, not much excitement. People are going to epigenome now. And epigenome is a mapping and constant changing of your genome with the meditation with the agouti mice, and you can change yourself. You can change yourself, reprogram yourself by good habits by meditation, and you can change your epigenome and also live longer and happily. So this is all science-based data that are corroborating with our ancient wisdom. Of course, 2 minutes. This is the state of medicine. That was the state of us. In crisis, this is state of medicine. We are actually have no meaning, no identity, no purpose. And again, the meditation not only comes to rescue as mindful MD, but also the mindful care. And this model, doctors, somebody mentioned Daniel Ofri's, this is a bestseller book. Everybody should read this book, How Doctors Feel. This is how we feel. We're burning out. We're burning out. And one technique we can do, very simple thing, is to spend 10 minutes in the morning, 10 minutes at night, and just meditate, mindful meditation, loving meditation, whatever you do, and energize and tune up your brain so that you have compassion and empathy. This is Brother Anil showed this compassion on the left side. But this is from JAMA by an artist who's a 7-year-old who went to see a doctor, and he saw the doctor sitting behind the computer. And she painted it, and it came in JAMA. And this is what we should be, and this is what we are now, electronic MD. You're not even looking at the patient, forget about compassion. And this is the study from Michael Kreshner and JAMA, who studied the mindful meditation in helping the people who are burning out. And it has shown definitely that your outcomes are better, your litigation is lower, you have more compassion, more concentration, more empathy, and better outcomes, and better quality outcomes, same thing, well-being. And this is what we need. meta meditation for mindful MD, for mindful care. And how to meditate? Very simple. Somebody was asking in the panel discussion, where do we go? And Dr. Martin or somebody, where do we go? Where do we find? It's very simple. Very 3 steps. If you have 2 minutes, I will beg the organizer, give me 2 minutes. And I would rather do it now. Let's sit down, practice this 2 minutes of mindful meditation so this talk is incomplete. Okay, all right. Thank you. Thank you for your attention.
Thank you, Dr. Sharma. It is with great pleasure that I introduce Dr. Yuglans Alvarez, our next speaker. He's a cardiothoracic surgeon in Brazil who had a wonderful career and then had an epiphany and his life changed. So he'll talk to us more about that.
Sairam, dear Sai family, it's with great pleasure that I'm here. Thanks for the invitation, Dr. Reddy. And I'm going to share it's more of a personal history. And talking from an ego perspective or personal perspective is very hard. It's very challenging because that's all that we have to get rid of is our ego. Anyway, I'm going to share some experience that I had as a cardiac surgeon in the southern part of South America. It's a very remote place for everyone in the world. But it's part of the global mission of Satya Sai Baba, for sure. And first, my background, I'm a Christian, Catholic. Was raised with a very strong Catholic tradition, went to Catholic schools, and but I always shared an interest in everything related to God, to universe, to nature, trying to understand what's the utmost meaning of life. Are we only this body? What else are we? And in that journey, 1991, I was about to enter medical school. I heard a lecture on Satya Sai Baba back in Santa Maria. It's a tiny little town in South Brazil. It's like 100,000 people, close to Uruguay and Argentina. And the speaker, by Swami's way, ended up some days at the ashram. And he shared his experience there. I was amazed by that miracle, man. But that stood at the back of my mind for many years because I always admire all the saints, the gurus, the great human beings that were able to manifest God itself. It was only in 2005 that I heard back of Satya Sai Baba. I was already trained as a cardiac surgeon in 2003, finished my training, I was working. And by that time, my wife got pregnant, our first child. And 2005, the Swami's way, everything started to coming, like pictures, books, people talking, and wow, there's something going on there. Because I also used to meditate, like you suggested, and it's very helpful, but beyond physical well-being, it gives you some kind of a connection with something that you can hear or listen or read signs much better. And that was what happened in 2005. I got the message, but from trying to get, again, rid of my ego again, I just kept assessing Satya Sai Baba by books, lectures, and discourses and everything. And one thing that I registered that you only will come to Satya Sai Baba if he calls you. And I understand the message. If that will happen, it will happen. I know that he is inside my heart. I know that he is everywhere. But obviously, I would love to be in his physical presence. And especially because I was a cardiac surgeon already. I would classify me as a spiritual person. I always dreamed of doing humanitarian work. And when I came to this picture of the hospital in Prashanthi Grand in rural India, doing voluntary and free health care for really needed people, reading the Swami's discourses, the Swami life, how deep spiritual truth was there, how strong that message was in the 20th and 21st century, how difficult is getting that done. I said, this guy can only be God. Swami, then I took the actual and real perception of Swami is. And then 2 years later, after lots of books, lectures, and discourses, I finally met some local Sai organization, 10, 15 people in Porto Alegre, South Brazil, that had us like our center there. And then by 2009, obviously I was dreaming of going to Prashanthi someday, but the call wasn't there yet. 2009, my wife came to me, I want to give you a birthday gift. I want to give you a ticket to Prashanthi. Obviously for her also. And, that year, we had a Brazilian delegation. More than 300 Brazilians were there for the Guru Purnima. And we were there almost for 3 weeks, and it was a unique experience. Lots of leelas. I promise you one day I will write a book. Among the most interesting things on that Guru Purnima was the 2 discourses that Swami made, the day of the Guru Purnima and the day after, talking about morality, our love for our duty, morality in society, and the role of the women in society. And my wife was and is an endocrinologist, a medical doctor, but Swami told about the importance of women being mothers. And that touched us, I would say, very deeply. And then we decided that we have to follow Swami's instructions or Swami discourse some way. But also we said, okay, Swami will show us the way. Okay, let's go, let's move. 2009, that year I got kind of a very strong feeling of connection with Swami. And 3 months later we had the convention here, October 2009, and we came. And then 2010, it's a very interesting episode. One of the things that I want to share with you, very interesting. 2010, we have the pre-World Conference in Buenos Aires, Argentina. And that February, the conference was in March. That February, I had a dream with Swami. Swami came in white. I already knew and was planning to attend the World Conference on Cardiac Surgery that would be in Chennai in October. Anyway, that I didn't tell Dr. Reddy this. I'm going to share with you now because we're a part of this story. And then I had this dream of Swami, and I told Swami, Swami, you know that we're going to have hundreds of cardiac surgeons and cardiologists from all over the world, like a few 100 miles from Puttaparthi. And I know that you only call to you, close to you, those you want. And Chennai is very close. What about doing a conference in Puttaparthi and show the world what's being done in cardiac surgery? Free healthcare, high quality. And Swami said, you can propose that. And then he went. Okay, I kept that dream in my mind. And in March 2010, like 6 weeks later, we were in Buenos Aires. In one of the hallways, I met Dr. Reddy. And briefly talked to him and said, Dr. Reddy, you know that we're going to have a World Conference on Cardiac Surgery in Chennai, October. What about doing something pre or post conference in Puttaparthi to show the world what's being done there? And he said, okay, I will ask Swami, but okay. Anyway, that was late March. By mid-May, Dr. Reddy sent me an email. So we submitted the proposal to Swami, and Swami accepted. And he said we should do the conference. But that was late May, mid to late May. And the conference should be in October, like 4 months ahead. So it won't happen because, how was going to organize that? And then, but obviously I believe Swami decided it will happen some way. Anyway, here we have the picture of what happened. Hundreds of cardiologists and many of us are here. And that's October. And we ended up having a wonderful conference. Swami attended 2 lectures, one on cardiac revascularization, other on echocardiography. And he was in assisting. This was amazing. Anyway, the conference was a success, very successful. And at that day, from that day on, I engaged more and more in the organization, and we started doing some seva, as you can see, in our underprivileged communities back in Brazil, South Brazil. I did a master's degree in cardiology and psychiatry, because in our university there was a World Health Organization connection on tools to research and measure spirituality. And I kept working as a cardiac surgeon at the public health system. So I had very good tools to put in practice all what Swami described. Be aware of what you ask to Swami, especially when you're in the Kuan Hall. I asked Swami, because I already was working with heart transplantation and heart failure surgery, and I asked him to have a deep understanding on what happens to donors and recipients on a physical and on a non-physical level in the transplant field. Because even if you read on the sacred scriptures, or if you read in the technical medical books, there's no mention to what happens to subtle levels. We know that we have subtle levels of existence. So I'm really curious about what's going on when someone has or is on brain death, and I go there and take the heart, someone get the liver, the lungs. I can feel some life there, but I cannot describe what's going on there. So I'm very curious about that specific field. As I said, we are body and soul. Our awareness by the time of transition between this life and the afterlife, our awareness fluctuates. What's the free will of that donor, that patient? We have a lot to discover on those subtle levels of existence. And obviously, it's an utmost act of love. So I was really curious about all of this. But Swami didn't give me a direct answer. He only nodded. And by that time, I already knew that this is yes. And then, but he didn't say what's going on. But what happened is, I went to the field to do some work on spirituality in cardiology and psychiatry. And finally, I say Swami guided our family to Canada when I got first a fellowship, then a position, a job on heart failure surgery at Toronto General Hospital, when we're doing a lot of vanguard research in terms of heart transplantation. I'm far away of getting at the subtle levels of existence, but we're doing a lot in terms of the frontiers of heart transplantation, donation after cardiac death. That is one of our transplants that we did. The big heart is the old one, and the little one is the new one. The little one works much better. And but donors, we're doing special work on donors because they are a fundamental fields, sometimes a little bit forgotten, because when you go there, we go with this concept, technical concept that it's a dead body with organs that are functioning. I changed that. I started a Canadian initiative, and now it's a policy in Ontario, where we stop the organ donation. Before we start the organ donation, we stop for 1 minute, and everyone can do what they want. I usually pray, internally pray for that soul have a good transition to the next life. And then We work on the DCD heart transplantation. That's heart transplantation after the heart stops to work. That's we're working with England and Australia as well. And working in heart failure surgery field in general with palliation. You have heart failure patients are at the edge of life, of physical life. So they are very prone and very open to discuss spiritual matters and spiritual issues. So in summary, I say that it's a life-changing re-encounter. It was and it is personal, it's unique, but mirrors experience from all over the audience. I know that everyone has experience with Swami that are very significant. And it shows because I'm from a very far cultural background, very far distance, how I came close to Swami. No matter where we are or now, or where or how we are, it shows no boundaries. Swami always is calling us. But it's important to stop and hear. He's inside us, he's everywhere. And it's part of a collective effort. Like me, we have thousands of people in South America. Dr. Roberto here was a friend from Brazil. So you be sure that Swami will be always and is always with us. And that's my testimony, let's say. Sairam. Okay.
At his request, I'll make this introduction brief. Thank you, Yogangs, by the way. Dr. Nadana Chandran, neurosurgeon from Australia, will be speaking next. I'll get a copy of it.
Sairam. I thank Dr. Reddy and his team for this opportunity to share our experience. This wouldn't be possible without, of course, Swami, who is resident in all of us, and particularly as Baba, the father. So may I wish you all a happy Father's Day. This is being celebrated in Australia, but I'm not sure whether it is Father's Day here. Okay. The work that I am about to present to you is teamwork. It's not one individual, and it's always been teamwork. And yesterday we heard somebody talking about sacrifice. Often we enjoy the work, but people behind us have to sacrifice, particularly a family. I'm particularly grateful to my wife for sharing this work and at times staying back and minding the home when I had to go out for weeks at a time. I was here for the 2009 conference, and I see vast strides being made by the membership, not in age, but in their effort and the action that they have shown us. And it is also heartening to see so many young people in the audience. That gives us great hope that Sai organization will flourish everywhere. There's no conflict of interest, and I'll speak on 3 issues, but the last one is only a touch and go. The first one is a neurosurgical service that commenced in 2001. In Fiji. Why Fiji? The Fiji island, with a population of about now 900,000, did not have a neurosurgeon. And the Royal Australasian College of Surgeons used to send a team of an anesthetist, surgeon, and a nurse once a year for 2 weeks. In between, patients either died, if they had money, they went overseas, or hydrocephalus became larger heads, and some became blind with raised intracranial pressure from tumors. When we went there, it was a pretty basic system, as you would appreciate in such countries. And if you look at, that's the main island where neurosurgery was in the capital, and they had a CT scan then, thank you. And later they had an MRI scan, but the MRI scan takes sometimes up to 2 months to be reported, but the neurosurgeon there now is able to deal with that matter himself. The Sai Medical Unit was formed in 1998 by Brother Hira and Dr. and Mrs. Sri Ramanathan when they had a national conference in Canberra. We were scratching around then, having been appointed as coordinators, not knowing what to do. We put a vision statement, a mission structure, and did a few jobs here and there, first aid, blood collection, and so on. But Swami says, if you have the yearning and you have the, show me your availability, I will give you the ability. And this has been a driving force in our organizational functioning. And when we then got this opportunity to go to Fiji to do neurosurgery, we had these aims: treatment, educating patients, transfer of knowledge and skills, training the medical students and junior doctors, giving hands-on experience, conducting seminars, donating equipment, and we became channel for expression of altruism of others. There are people who want to help fellow human beings, but they do not know how to do it. And when they see an opportunity, they come forward. Recently, we had a surgical team going to Fiji with our clinic, and they were given $50,000 worth of instruments and medical supplies for laparoscopic surgery by Johnson & Johnson. We have had a number of companies helping us with shunts, drills, etc., that we needed in Fiji for our work. We become ambassadors of goodwill, particularly if you look at the scene in Fiji. It went through 3 coups. The cohesion between the Indian community and the Fijian natives was quite disrupted. And the presence of people like us coming and helping the whole country, we felt was a way of bringing some degree of friendship between the divided communities. The neurosurgery visit averaged about 20 operations, 100 consultations in the 2-week period. We donated books, medical supplies, and equipment. Fiji still needs a lot of equipment. If any of you want to go and work there as a neurosurgeon or are prepared to supply them with some pre-loved equipment, I'm sure they will receive them. They do not have a modern microscope. They do not have neuronavigation. They do not have even an ultrasound aspirator for CUSA or Sonoca for treatment. We're struggling to give them some. Last year, we managed to get the Australian government donate $60,000 for an electric craniotomy drill. So in the process of doing this work, we found that people were waiting for a year to be treated sometimes after we left. And we then started a second team visit through community funding, supported a bit by the Sai community there. And then we found that it was possible to isolate a guy who would be prepared to be trained as a neurosurgeon, gave him a paid job in Canberra for 2 years where I was working, arranged a scholarship for him to do pediatric work for 6 months in Sydney, and then trained a neurologist, trained a radiologist. And the ACT government, then that's the Canberra government, came up with a scholarship for nurses, which is still continuing. So that's the state of the neurosurgery at the moment. I'll show you some figures of the throughput of the surgeon in the last 4 years. While this was happening, the Fiji Sai Medical Unit started a visit under the leadership of Dinesh Lal, who is an Indo-Fijian, now a gastroenterologist in Auckland. We heard about that, and our doctors joined that team for a year, and subsequently they went on to doing further work there, and we joined them, and then we branched out subsequently in 2007, and we have now 11 years of annual visit lasting about a week. We also hold camps in the rural areas and also have 2 seminars for the medical schools and the local doctors. If you look at the team, we have since last year a surgical team as well, doing work at the local hospital. We have general practitioners, dentists, ophthalmologists, optometrists, gynecologists, nurses, physiotherapists, and various other disciplines coming with us. We have about altogether 100 volunteers, about 57 travel from Australia. The New Zealand team has 97. 50% of their team last year, or this year, were non-Sai, if you want to call them as non-believers of Swami, but they were prepared to work in this capacity, again highlighting that we become conduits for the goodwill of others. The output last year was 1,273 patients for 4 days. This year it was 1,700. And each patient can go to more than one discipline, eye, dental, gynae for women, and medical clinics, and physio, etc. So the New Zealand team had 2,765 this year, and their services would be probably multiply that by 3. What's the impact? We can come back and say we had so many people treated and be happy about the figures. What do we influence there? For us, the most important part was the reaching out with compassion, love, respect, and dignity, which apply to all the people involved, patients as well as the people who were doing the work. Patients came and said, "Doctor, you're touching us. Doctors here are so busy that they just write the prescription as they see you." So that they felt that there was some humanity behind the work that we were doing. We transfer skills and human values in medicine. We have medical students following us, and they see how medicine should be practiced. It is very important for the next generation of doctors through that service. We assisted in the establishment of the neurosurgical service. Since 2013, 728 operations have been done, 90 cranial tumors, 106 for trauma, 102 for shunts. There's a high incidence of neural tube defects and spinal procedures. This despite having really basic instruments lacking. There have been dental equipment donated to Professor Rajat's Visesi Center, about which he will talk later. One of our pediatricians did a study on premature births, and the surgeons that come with us now are establishing a link like what we have done with neurosurgery to provide a proper service to Fiji. So if service is transformation, we give only a little to the people, and in return we get much more, as you will see from the size of the arrows in exchange. There are collateral gains that we have talked about. And I just want to cite the experience of a nurse volunteer who says, a lady who had lost her husband addressed her and said as follows, and then the nurse says this: "She hugged me so tight for about 5 minutes, and not realizing my hands, reached out to wipe her tears. When she could finally control herself, she looked at me and thanked me, still with tears, and said, 'You know what? God sent you all.' She seemed so much at peace. Such is the love of Sai." This has been quite a common experience. And for all this, we are grateful to Swami, the patients, the team of volunteers, the Sai family, the schools that accommodate us, the Ministry of Health with whom we have very close working relationship now, the Air Pacific, which at one stage gave us free tickets for 3 of us in the neurosurgical team, the donors of medications and equipment. This is the last one that I have to touch on. 2 years ago, an initiative from Canberra brought this aging workshop where we had about 100 senior citizens. Some of us are not yet senior citizens, I can say that. And what we did was we had 6 tables surrounded by the participants and a specialist or a doctor or an optometrist in the middle discussing certain issues. Then after 20 minutes, they moved to another table. And this was a very successful meeting, which is now going to be replicated in Sydney and possibly in Adelaide. I'll just pass through some pictures to show you the journey of the neurosurgical work and the clinics that we run in the rural parts of Fiji. These were patients that went blind waiting for a neurosurgeon to come. Here's a recurrent meningioma, which eventually went to India because it is cheaper to have surgery in India than in Australia or New Zealand. It's 1/3 the cost. A child had waited for hydrocephalus to be dealt with. The mother of the child that after shunting was happy. And this guy is the neurosurgeon that we trained in Canberra. He's very active. He's now training a second guy for whom we will find a job, hopefully in Australia in a year or 2, to continue his training. Now this is the team, and I want to say a word about the team that we have. This anesthetist came with me for 11 years, every year. He's not a Sai devotee. He doesn't go to church. He doesn't believe even in God. This is another nurse, and these are the local staff and the surgeon. This guy came to me for a few years, had a lymphoma, treated after that, came back on the camp. Then 2 years later, he had acute liver failure, had liver transplant done, and insisted on coming with me again, and his liver surgeon allowed that. He also goes to Gaza with a pediatric surgeon every year to do assistant theater work there. The place where we are now doing the camp is this island. Swami says, service should be done where there is a need. We found that the New Zealand team was doing good work here, but this part was neglected, so we have moved over there in the last 3 years, which means the logistic of carrying 57 people, booking their seats, and so on. So in doing this clinic, there's extensive planning needed. We have to arrange the accommodation, the food, the transport, all that. It is done through the volunteers that we have. This is our team. We have no hierarchy. We have managers, leaders, but we all work as a team. Every little work is important, as was the case of the squirrel in Ramayana, where the squirrel had to go and put the dust or the sand on the beach to build the bridge. This is the leaflet that we send across. This is the conference agenda. This is Dr. Gunanakar, our team leader, who does a tremendous job. He does most of the organizing, and the others form part of our team. The guy in blue is the logistic manager, but he's multi-talented or multitasking. Who said that men can't multitask? He's a guy who does so many jobs that is pretty a great asset to us. So these are the patient journey, the dental, the eye, and then we have the data entry people. This is the surgical team. And in conclusion, we work with the realization that nothing moves without his will. We treat and he heals. It is love in action as compassion, altruism, sacrifice. Lessens our ego, contributes to inner transformation. We become conduits of the altruism of others, spreading human values to wider community, plant the idea of service among the students, spread the concept of unity of faiths, and we benefit in a number of ways. Thank you. Sai Ram.
Let us break for 10 minutes instead of the scheduled 20 in order to respect our speakers and hear what they have to say coming up. Please don't forget to sign the CME forms and the signature forms. Both forms need to be signed. Thank you. Nurse in the endoscopy suite, and he was instrumental in setting up the endoscopy suite at the Sri Sathya Sai Institute of Higher Medical Sciences. So without further ado, please help me introduce Mr. John Whalen.
Good morning, everyone. I have no disclosures, but I need a microphone. There we are. So 9 years ago, I was a clinical manager in a very fast-paced endoscopy department at a major academic medical center. It was that professional experience and skill that provided valid foundation for my involvement with setting up what would be the GI endoscopy unit at the super specialty hospital in Puttaparthi. I recall that in the preliminary conversations with my physician colleague Hari, he stressed that my experience and credentials counted, but what kind of person I was mattered as much. That struck me as very different from any work expectation I'd ever known before. It is more common for people to care most about what you'd accomplished or what you could produce than who you were as a human being. Well, this foretold what would be not just a professional work experience, but a very unique and powerful life experience. My initial reaction to being asked was feeling genuinely humbled that I could have something to offer people halfway around the world. Who was I? What did I bring to the table? From my inexperienced perspective, I didn't realize the community that already existed. It was that community that would launch this endoscopy unit, not just any one person. I also didn't realize that what was needed was the basic tenets of healthcare as much as my skill and experience. Still to this day, I feel so very fortunate to have helped with the beginning for this endoscopy unit. What affected me most, though, if this were a TV program and you were scrolling through to see whether you wanted to watch the show or not, it would be titled something like Very Internationally Experienced Midwest Boy Gets a Bigger Perspective. As much as I was an adult, I'd never traveled out of North America before. I remember on the flight to India, I was like a kid looking at the TV monitor on the seat in the back in front of me. I was realizing I was flying over places I'd learned about in grade school or just saw about in the news. So it was with some of this childlike wonder that I stepped into the cool, fragrant air in the middle of the night at the Bangalore airport. I stepped out into the first fresh air that I'd had since walking into the airport in Michigan, which was only a day earlier, but it was a whole world away. My senses opened up to a new world of sights, smells, sounds, and colors. The 2.5-hour drive to Puttaparthi was honestly very surreal. For one, because I'd only slept about 3 of the 17 hours of the flight. Brightly colored lorries, Brahman cattle on trucks, decorative flowers, tea stands. As much as I was dog tired, I was intentionally fighting off sleep so I could take this all in. We started right in that next morning. The first week would be physical setup and training of the nurses. We'd start procedures in the second week. The nurses were so appreciative and dedicated. Their devotion was obvious. It was really impressive how far people traveled to be treated at this hospital. This was so much different than the mostly elective, sometimes arbitrary, and very much taken for granted healthcare I was used to in the United States. I was so impressed with the providing of free services for so many people. And people genuinely appreciated and needed even the most basic services provided, what we take for granted. I also learned of the native volunteers who also traveled often very far to dedicate their time and provide supportive work. They were so sincere and fervent in their approach to what many of us would consider in the United States as very mundane tasks. The experience with healthcare colleagues struck me as well. I remember the very calm and unimposing manner and personalities of the physicians involved. Remember, I come from a U.S. academic medical center where titles and initials after your name mean everything. But in Puttaparthi, we were all there for a shared purpose and a common cause, service to others. There were no personal agendas. It became obvious very quickly that I was part of something much bigger than any one person. I met people from many other countries who were there to donate their time and expertise on behalf of the common good. The generosity of spirit and sincerity was remarkable. I was surrounded by kindness of character. So I came back to my hospital and my role feeling like I accomplished something so much bigger and better than anything I'd ever done before, feeling like it mattered so much more in the great scheme of things. What I ended up with was a life lesson in basic human values. It didn't matter that I couldn't speak the local language or that I looked physically different than the patients or most of the staff. What matters is what matters most in the service of healthcare. I've been a nurse for 34 years now. I believe the basic human values instilled by my parents and my faith led me to a career in healthcare. From early on, I was taught to help those in need and that everyone deserves respect. The best of what we can offer is service to others. To be truly effective as a caregiver, one needs to be both in the moment with others and truly in service to others. One also needs to role model through their actions. It's not enough to give lip service to concepts of charity or service. Providing ideal health care is about the other, not the self. It's about helping others and expecting absolutely nothing in return. It's about humility. One can have all sorts of initials behind their name, but that's not what the customer needs. For years as a manager, I would tell staff, new staff and veteran staff, that people came to our academic medical center expecting that we had all the knowledge, all the skill, all the latest toys. But what makes or breaks their experience is how you treat them as a person. Did you make eye contact? Did you address their concerns in comfort? Were they truly heard? Were you truly in the moment with them? I was so lucky to have this experience and get a bigger perspective on what service to others means. The bottom line, though, this wasn't about me or any one person. It was about all the people this can and does help. I learned so much about sincerity and service from everyone involved. It was Dr. Hari. It was the driver, Raju. It was the nurses, Prima and Kanya. It was the physicians from all corners of the world. It was the Indian volunteers who cut the sheets of gauze and prepped the supplies that we would use. It was the Dobis who washed the clothes. What's being accomplished in Puttaparthi at the Super Specialty Hospital and through the Sai organization is healthcare delivery that very practically and genuinely exemplifies the message on the archway of the hospital entrance. Service to man is service to God. Ideal healthcare delivery requires an open mind, open to others' beliefs, lifestyles, and concerns. Especially in light of recent world politics, we need to be reminded that it's important to pay attention to more than your corner of the world. There was and is a great need for the education, experience, and physical resources we so often take for granted. We need to genuinely care about what happens elsewhere. We're all responsible for humanity. Humanity is not the individual, it is all of us together. Public health, global health. These are more than subject titles or focus for an advanced degree. It's the essence and awareness of how we can and should help others. Thank you very much.
Thank you, Mr. Whalen, for the reminder that there's no I in team. Michael Jordan was wrong. He said there was an I in win. Dr. Geeta Govindarajan is next. She's MD, PhD, MPH. She's currently the Associate Medical Director of a community clinic in Chicago. Thank you.
Good morning, and Sairam, and I deeply offer my humble salutations to the divine in each and every one of you. Thank you for the opportunity to be here today and to share a little snippet of my medical journey with the rest of you. I begin my slide with introducing you to the main protagonist of my talk, the lady who coined the term "I have no complaints" and now happens to be the main reason or the title for my talk. This is Laverne Everhart. She is our lead medical receptionist at the Friend Family Health Center, where I work. She has been working there for the past 11 and a half years. She is the epitome of positivity in our clinic, and no matter which day of the week it is, no matter what day of the hour it is, no matter when you ask her, "Hey Laverne, how are you doing?" her response is always an emphatic, confident, "I have no complaints." And she always says it exactly the same way. And it doesn't matter whether you're a provider, you're an MA, you're a nurse, or you're a patient. It's always the same. It's interesting, right? Because my day begins with complaints. I'm a primary care health provider. I have a patient panel of about 5,000 patients. I practice in the south side of Chicago, which I'll come to in a second. But complaints is just such an integral part of being an internal medicine provider, chief complaints. But what is fascinating is this upstream thought that this lady has managed to echo through my head now for the past 4.5 years that I worked here at this clinic, and trying to see what she means by that. Oftentimes complaints, in the last 4.5 years I've progressed from just being a clinician to more of an administrative role in this organization, and I get complaints from my providers saying how their schedules are overpacked, how they don't have enough staff needs, they don't have resources, et cetera, et cetera. The laundry list goes on. And in all of that, and my own schedule is packed with 20 patients for the first 4 hours. Sometimes we have 3 overbooks, 4 overbooks, depending on which day of the week it is. And how do you try to practice ideal healthcare in a setting like that, in trying to incorporate what Swami has taught me in my personal journey? And I think that's been the interesting, conundrum that I've had. And ever since Dr. Reddy and Hari Uncle have been asking me for the title of my talk, and after I've given it to them, I think it's been increasingly more harder to try to understand what this means, because it seems like the complaints have exponentially increased, and that's how Swami tests you. And what is fascinating in understanding all of this is also to pay attention to how we as providers can be resourceful to these patients who are coming to these health centers, not truly giving you their concerns and expecting you to transform their complaints into something tangible that they can walk away with. How can we create a space that would allow them to transform their complaints to an advocacy state, which is what I feel like Laverne does for our clinic. Laverne is a recovering cocaine addict. She is a breast cancer survivor, and additionally, she also had a stroke, which left her with right-sided residual deficits. I just want to take a moment to explain to the audience what a community health center is in the United States. It's in the primary care setting, 1 in 12 Americans use the community health center for their healthcare needs, and there are about 1,400 health centers all across the country, serving about 26 million people. And the mission that was under which these community health centers were created about nearly 50 years ago was to provide high-quality, cost-effective care services just about to everyone, regardless of their insurance status or their ability to pay. And the goal of them is to offer service to just about everyone, which is in alignment with what Bhagwan Satya Sai Baba says. And the beauty of it is it's community-owned. So it's a medical home for the communities that live in that particular area, and half of the board of directors are part of they actually are community health center users themselves. So to me, working in this community health center has been a life-altering experience, because I have learned leaps and bounds from each and every patient that has walked in to my office. The speakers that have spoken over the course of this conference have always talked about creating a space in which the patient is able to open up. And to create that space requires you to be an active listener. Half of the healing happens in that space. I am reminded of a speaker that spoke to us during residency, and he was a speaker who used to attend to the Dalai Lama. And what he said has left an indelible impression in my heart, which manages to tell me that this is how I should operate, even though it seems like my schedule is filled with tens and thousands of patients, and I feel like I'm not able to do justice to these patients, which is simply that you never treat the person that comes into your office as an ordinary person that walked in. It's an extraordinary moment that has been divinely designed for many a decade, many a centuries, many a lifetimes. Imagine when you start thinking about all the steps that you had to take to get to this point where you were able to serve this particular patient, and think of all the steps that this person took to come to your room, to open up their heart, their soul to you. This is not an ordinary moment. It's an extraordinary moment. The moment you start thinking about it and see the patient in that light, you realize that this is not you working, that there is a divine principle that's working through you, and that's when the healing happens. And when I think about that, it blows my mind. And it's such a privilege and honor to work for these patients and their rights. The south side of Chicago where I work is the hood. It's on the south side where, commonly, the statistics are high for gang violence, for drugs, for failing schools, foreclosed properties. And it's such a juxtaposition against the beautiful skyline of Chicago that everyone sees. And this has been my learning ground ever since undergrad onwards to now. Through the Satya Sai organization and the young adults, and several of them are here today, our journey began there because we spent a lot of time, almost every weekend of our either grad school or working period at in these neighborhoods where we did work with the youth. And these programs included educational programs, mentoring programs, and now, more recently, in the free clinics that have been set up through the Port Ministries, which is a Franciscan ministry that works specifically to offer free healthcare to those that do not have insurance. And it's a sizable population there because we have a huge migrant community and a lot of undocumented workers live there. And so this is a free community. A lot of our youth go and volunteer. And what we found that through working in my organization and also through this, there are several areas where we're not able to truly reach out to the patients just because these patients are not willing to come to the clinics. And that's when we realized, like working with the Satya Sai Mobile Hospital in Puttaparthi, that it is sometimes necessary for us to go to the community. And that was the main thought behind this particular project that me and one of my other young adult colleague here, we embarked upon this project through the Schweitzer Fellowship, which is the HOW, which is Health on Wheels. So our idea was to basically do a mobile outreach intervention to take preventative health dialogues to their doorsteps. So by partnering with the bread truck that was already delivering food, we added a health component to it, which was educational, screening, and access issues, and tried to reach out to this community. And the results were phenomenal because these patients opened up and they came back, and we were able to loop them back into the different healthcare centers in the neighborhood. And so these are some snippets of our conversations with these individuals in the community, and it's an ongoing process, and we're going to continue to work and build on them. And I just wanted to throw this in there because when you work in a community health center, it's an interesting experience because what walks in through the door, you have no idea. This is a gentleman who's 80 years old who works and has grown up in the south side of Chicago. He asked me 1 year prior to him coming in with his bag of okra and tomatoes what my favorite vegetables were. And mind you, in the hood, there aren't any community gardens. There are only concrete jungles, at least in the area where he was living. He's like, Dr. G, because that's what they call me, and Dr. G, what do you like? And I said, well, my favorite vegetable is okra. He's like, okra? What's that? And so he had never heard of okra. And I tried to explain it to him, but the encounter was brief, so he went away. So this gentleman, at 80 years of old, and he had lumbar stenosis and whatnot, and he ended up researching what okra was. He brought seeds. He had to go outside of Southside to get these seeds, grow them. 1 year later, this is what meets me on my desk, saying, Dr. G, here's your okra, because he still can't say okra. He's like, here's your okra. Make sure you make something good out of it, okay? So what other way can you even begin to sort of see how these community members see you as their own family members? They pray for me when I take an exam. They pray for my parents if they're going through some tough time. They become part and parcel of this extended community that we are. And the only way that happens is that when you accept them as part of your family member, when you begin to think of themselves as your own kith and kin, and then that's when you practice medicine in its entirety, the way Satya Sai Baba has laid out. And to me, there's been three things that I just wanted to briefly conclude with, which is the individual journey, creating value in the journey, and maintaining balance in the journey. I think as a youth force, we have the incredible ability to mold what the society, to work with society and create, lasting impressions. And we can take the advice that we have from our elders and transform them in a way that will make sense for the communities that we work in. It is important for us to think locally, think globally, but act locally. And so I think this is a clarion call for all the youth that are here to take inspirations from all that you've heard in the last couple of days and see ways in which you can go back and impact your communities. And so in closing, I want you to just listen to the words of Laverne, because I could not conclude the speech without letting you hear her words.
Hi, everyone. My name is Laverne Everhart, and I work at Friend Family Health Center as a senior lead medical receptionist. I've been employed at the Friend Family Health Center for about 11 years. For me, I take each and every second of my life as a precious moment. Life is beautiful, and life is a blessing. So no matter where you are, what you do not forget this mantra, the mantra that always enlightens your moment and keeps your smile with you. I'm sure you will need this down the road, and the mantra is, I have no complaints. Take care, everyone, and enjoy the conference. Have a blessed day.
Thank you, Geeta. May we all deserve okra from our patients. Our next speaker is impressive even amongst a list of impressive speakers. Dr. Kalpalata Guntapalli is Endowed Chair of Critical Care and Professor and Chief of the Division of Pulmonary and Critical Care at Baylor Medical College in Houston. Dr. Guntapalli.
Thank you. I want to thank the organizers, Dr. Narendranath Reddy, Dr. Ganesh Yadlapalli, and Hari Kanjuvaram, for allowing me to speak today. My talk is going to be entirely different than what's published in the brochure. When I was coming, Dr. Reddy asked me, like maybe yesterday or the day before, he said, why don't you talk about Hurricane Harvey since you're just coming from that area? So if I get through that, then I'll get to the real topic. Thank you. I moved to Houston from University of Pittsburgh in 1988. Over these 30 years, I've seen a lot of hurricanes and tropical storms. However, I'm just, sharing some experience over these 4 tropical storms and hurricanes. The first one is Tropical Storm Allison that occurred in 2001. It dumped about 40 inches of rain. And what is interesting in this is that Hermann Hospital, which is a big hospital system, had to evacuate 600 patients by stairs by several floors. And this was made into a movie by one of the cable channels. The second one was Hurricane Katrina, which was in 2005, which many of you heard about from previous speakers. Houston didn't get hit as much. However, there were 250,000 refugees from New Orleans area that came to Houston by bus loads. And we set up a 40-bed clinic hospital complex for about 45,000 people who were living in the Astrodome area. And in this Hurricane Katrina, more than 1,000 people were killed between Louisiana and Texas, so it was pretty devastating. There was Hurricane Rita in 2005, and Ike in 2008, where 21 people were killed, and it was also in our area. So Hurricane Harvey hit Houston it made landfall at Port Arthur area, south of us, at 130 miles per hour. And the rain that was registered was more than 50 inches, and it actually broke all records in the continental USA. It was described as 1 in a 1,000-year flood, and because it was an exceptionally rare event. However, Houston has been hit by what is called 1 in 500-year flood, 3 of them in the last 3 years. About 300,000 citizens of Houston area were left without power. And this hurricane is described as the one with 1-2 punch. Basically, you get hit first, then it goes back into the Gulf area, picks up speed again, and hits again. Fortunately, we were not hit as bad a second time. Just want to tell you where I work. This is Texas Medical Center, and Houston happens to be the 3rd largest city in USA with 6.5 million in the greater Houston area. It is the largest medical complex in the world. It is situated on 1,600 acres of land. It is home to 22 institutions, 2 medical schools, 14 hospitals, and each day 105,000 of employees come to the Texas Medical Center area. And the underground facilities in Texas Medical Center are as compact as Manhattan. There are about 4,500 hospital beds in this very concentrated area, and 3 of the top 5 hospitals a few years ago by US World News are located in the Texas Medical Center. If Texas Medical Center was a city, it would be 18th in the US. And you can see that, I just want to point out to you a couple of, I should do it there, I'm seeing. So there are a couple of streets. This is called Fannin Street, this is called Main Street, and these are the main ones that go. And here in the background is your downtown Houston, and this is the Texas Medical Center area. And this goes this way, and Main Street is both ways. And these are the 2 main streets that actually lead to the medical center. This way is MD Anderson, and I'll show you what happened there. So what was the state of the city of Houston when Harvey hit? So 8,700 flights were canceled, and I think I was the first one on the day I came. And a lot of them flights were really evacuating people who were stranded. And the economic impact is significant. It is supposed estimated 190 billion loss. And next is really Katrina, which at $50 billion. So this is downtown Houston in the background. This is Highway 45, and you can see a big truck that's pretty much submerged in downtown area. I'll take you to Midtown area. Can you play the video, please? This is a Midtown area where you have these colored building here, and this is Galleria up on this side, and this is how the whole city was looking at it from the Midtown. The next video I'm going to show you is very interesting, where you have the same streets in 2016 and same buildings that were there before, and now how they look like in the when the Hurricane Harvey hit. Can I have that next video, please? So on the one side you see 2016, and this is same buildings. You can see that they're the same buildings and how they are now. And the street names are up here. So you can see the same, buildings up here on the right side and left side, same building, but you can see how much water is there. This is
Market Street's now Lake.
Market Street is in downtown. This is Meyerland Plaza, about a mile from my house. And I live 2 miles from Texas Medical Center, so this is pretty close to Texas Medical Center. Can we go to the next slide? I think you get the idea. So what was the state of the Texas Medical Center? Next slide. So this is the University of Texas MD Anderson Cancer Center. I'm sure you've all heard of it. And it really spans over many buildings. It's not just floor of a hospital, but probably 8 or 10 buildings. And this is actually the lobby of MD Anderson, and this is what it was. People couldn't get in or out. So this picture here, this is MD Anderson building, and we are really looking at somewhere here. So this is a street. This is Fannin, Maine, and this is somewhere here. You're looking at it from there, looking towards here, and this is actually one of the Anderson buildings. So this kind of hits close to home. I just wanted you, I don't know if you can see it well. This is one of our friends. He's probably in his 30s, and they live about a mile from me. And his house was flooded. They just bought the house in March. And a young family, 2 small kids. And this is him. He's about 6 feet tall. This is actually a day after it kind of lightened up, and he's just trying to get to his house to get some stuff. And they have 2 small kids, and people are going in kayaks actually in these streets. And one of the things you can expect, he killed 3 snakes when he went back to the house just to take photos for the insurance purposes. So this is the same person I was telling you. Can you play the video, please? So he's taking a video for his insurance purposes, and you can see him sloshing, you can hear him sloshing through the house. And so he said there was about 2 feet of water in his house when they ran to the neighbor's house. And this is his kids who are sleeping. Very cute kids. They didn't know what's going on, so they had to put them on the kitchen counter, gave them little cell phones to play with, and then they had to go and really pack like the food and some essentials before they could run to the next door. So can I have those videos playing? This is my secretary.
Storm, I lost my car. It was just parked in my regular apartment, but the whole area was completely flooded, probably about 5 feet of water. It covered.
A lot of cars got.
Yeah, a lot of cars got flooded in. So, but thankfully, I didn't lose electricity or.
Can you play the next video, please? So I ran into this gentleman in the elevator when I was coming to work on Friday. Is it playing or not? It should have a separate button. And I just asked him, how are you? How was your home? And he said, oh, my home is okay, but I was at work. I said, what do you do? He said, there's in downtown Houston, there is an aquarium, beautiful, huge place. He said, I'm a property manager there. And then, all the fish and the animals would die because if I don't feed them, oxygen is out and the air is not coming in. And then afterwards, he, recorded that. And then I said, who are you visiting after I stopped? He said, oh, I'm visiting one of my divers who got stung by a stingray. So these things, we don't think of other professions, but, this is the hospital that I was actually doing duty. This is a level 1 trauma center. It's one of only two level 1 trauma centers. They're unfortunately situated next to each other. Both of us got flooded. So this is actually a 560-bed safety net hospital. 60% of teaching of our medical school is done at this place. Both police and prisoners, when police get shot and prisoners get ill, they both come to the same hospital. So we have sheriff briefings, and there were structural breaches. And the first day, we had to declare a state of internal emergency because some of the pipes broke in the basement, and the nutrition department was there, and the pharmacy needed to be evacuated very fast. Hospital operations, they declared an internal disaster. And unless they say they're in a recovery phase, you cannot really go to normal operations. So no elective surgeries. There's something called ride-out crews that all of our hospitals have. So you bring in 2 sets of crews, 2 sets of nurses, 2 sets of interns, and one group sleeps and the other actually works. So you cannot leave the hospital unless you actually shake hands with your reliever. One mistake was made in one of the ICUs. They let the nurses go. The nurses never made it home because they were stranded in the water and the relief never could come in. So it was a disaster. So you never let them go unless you actually shake hands, not just in the building. They say shake hands. So you prioritize your list. We were on evacuation, but we only evacuated 5 patients because we didn't have enough food to feed the patients, and we sent all the families out to the evacuation centers. And so you prioritize in the end, we never ended up sending patients because some other hospital got flooded. They had to evacuate 200 patients. So there's a curfew even now to avoid robbery. So, we had to give badges, and this pharmacy had to be evacuated within 15 minutes from the basement to 4th floor. So everybody ran down, picked up whatever they can. Otherwise, we can't function as a hospital. They were moved to the 4th floor. And this is a badge we have to show if we are called when there is a curfew now. So this is the command and control center. And that's where we get briefings. Can we go to we get briefings every day, 8 a.m. and 8 p.m. And there's police giving briefings. Everybody gives briefings there. Very important communication is done there. This is Dr. Novakovic, one of the internal medicine faculty. He was coming to work, and his car got drowned. And so he had to actually break the windows, crawl out, and swim to come to work. So these are really very, dangerous times. And this is a view from one of my niece's house. Nothing happened to the house, but you can see how much waterlogging is there. Yeah. So this is our ICU team, and, we are, everybody's happy. And these are our nurses taking a break and sleeping. This is the off nurses. And this is on the left side. I always tell my residents and fellows, it's education beyond books. You're never going to learn what happens here. I take them for briefings and everything. It's very, very important. And we are at 72 hours of 96 hours, and we are still smiling. And, our nurses and, so everything that could go wrong, like Murphy's Law, went wrong. I would say even if there was no Harvey that week, any day of the week out of the 52 weeks, on the brightest day, it was the worst ICU week. All kinds of complications, and cardiologists were not in the house, GI was not in the house, dialysis left 2 nurses for us who would dialyze. So it was unbelievable. Even on the last day when they were declaring that we are recovered, it was just amazing complications. So the Houston community got into trouble. This is our experience with Katrina, where we had all these people that came from New Orleans, except we were not hit, so it was good. So this is a publication, what happens afterwards, and here, 11,000 patient visits, radiology, 382 x-rays, and what happens, mostly uncontrolled hypertension, respiratory infections. Important thing is norovirus infection that happened for 400 patients. So this is what is happening in George R. Brown Convention Center, and I'll just stop because my time is up. This is some of our fellows and faculty helping. So this is what we're going through now. And I just wanted to just give few rules. Self and family welfare is very important. Do not challenge nature. Check on water supply at home and so on. Many of our faculty, a third of our faculty of 49 people got flooded, so they couldn't come to work. At least half of us lost, even us, power. Some lost water. I had a fellow whose baby is 8 months old. They had to fill their tub with swimming pool water just for toilet flushes and so on. So do not hesitate people for work. And this is, 500,000 cars are gone. It's a marathon, it's not a sprint, so don't exhaust yourself. So it's about endurance, not a point performance. Sleep is very important. 16 hours of not having sleep is legally drunk level of performance. So you will have errors of omission and commission. Evacuating patients may be more dangerous than that. So I think I'll stop with this, and that's it. Thank you.
Thank you, Dr. Guntapalli. Incredible disaster in Houston. Our thoughts and prayers are with the entire city. Our next speaker is Dr. Gyaneshwar, who is former dean at the Fiji National University. Himself and Dr. Naidu have done incredible work in Fiji, which he will discuss. Thank you.
Thank you. My gratitude to Swami for allowing us this privilege, and thank you, Dr. Reddy, for inviting us to speak. And Nadna Chandran, you not only have helped Fiji in many ways, but you've also facilitated us being here today. Thank you very much. The journey that I'm going to describe is really part of our sadhana. And Fiji is situated in the middle of the South Pacific. From all the problems that you've had with Harvey in Texas, what I'm going to say now becomes minuscule. And I think that is really true about life in general. When you look at other people's problems, your own problems are nothing. The population of Fiji, as Nadna said, is about 900,000. The population is divided into two ethnic groups. One, the Itokes, the original inhabitants of Fiji, who arrived there about 3,000 years ago. And then we, the Fijians of Indian descent, are descendants of about 60,000 Indians who were taken to Fiji from India between 1879 and 1916. At the time that the Indians first came to Fiji, Fiji had a high mortality rate due to a high perinatal mortality and maternal mortality rate. But diabetes and hypertension was not known. Today, 80% of deaths in Fiji are attributed to NCDs, and many of these deaths are occurring prematurely. What I'd like you to see here is the fact that whilst in Australia and New Zealand life expectancy has been going up, in Fiji it has tended to plateau at the age of about 63. And what is even more worrying is that amongst women, Itoke women, their life expectancy might be less than that of their mothers. Women's health issues include poor contraceptive prevalence rates, adolescent fertility rates are high, sexually transmitted infections are high, cervical cancer rates with case mortalities are one of the highest reported in the world. And in many countries, cervical cancer is not a disease that is prevalent because of screening. In Fiji, only about 8% of women get screened. The political instability in 1987 led Swaran and I to leave Fiji because it was difficult to survive in that context. We spent 23 years in Australia, and then under the influence of the Australian SAI medical team, we felt that we needed to return to Fiji and do something significant as far as our service capacities were concerned. Over 40% of the population is at poverty level according to World Bank. Alcohol abuse is common. Domestic violence rates are very high, with about 64% of women reporting that they've had an experience of intimate partner violence. In context, the health budget for Fiji is minuscule. I'm not going to talk about your US budget because I don't think you manage health very well in the US. But let me say that in Australia and New Zealand, where health is probably managed a lot better, they spend something like 20 times more per capita on health than we do in Fiji. So we need to take things into perspective from that point of view. In this context, Visesi Sai Health Center was set up. This is owned by a charitable trust, which Swaran and I set up through Swami's grace. And we have a memorandum of understanding with the Ministry of Health, who provide us with a doctor and 3 nurses, some consumables and medications that allows us to run a outpatient service. And then we bid for project grants that funds our primary healthcare program. Let us now just think a little bit after what Mohan had said earlier on day one. As far as indicators for NCDs are concerned, Fiji was reputedly to be one of the worst performing gold medalists in the stakes. Obesity, overweight people account for about 60% of our population. Hypertension and diabetes in the last 10 years has risen dramatically. What you need to know is that in the 1960s, diabetes was virtually unknown amongst the Ethiopia community. We actually conducted a baseline survey in Fiji, which is here. That is because we thought if we did a baseline study, we might be able to see what impact we make after 10 years of interventions that we have planned for the community. Now, in dealing with the health challenges, of course, we do provide curative health services like any other primary healthcare unit would, and we see over 100 patients a day with a significant number of high-risk NCD patients as well. But our main focus has been preventative health. And the preventative health is designed to empower the communities through awareness raising, information and education, advocacy and screening. Now, this is a completely new paradigm for Swaran and I, who've spent about 70 years in curative health, and we knew very little about primary health care. We go out into the rural communities, we listen to the people, we provide information and education and advocacy about lifestyle risk factors, but the most important thing is that we work together in trying to identify interventions that are going to work. We work with other sectors other than health to ensure that education, women's health, Ministry of Women and Child Welfare, youth and sport are all involved in our intervention programs. This is something that links with our spirituality, but the thinking behind this was that of a Fijian primary healthcare doctor, Dr. Tukana, who talks about gifts of life and the fact that if you want to maintain health, you need to preserve these gifts. If you abuse these gifts, then, like the tree that was mentioned earlier, it'll shrivel and your health will be destroyed. To do this work, we needed help, and the help was made available by us identifying community people who could be trained over a 2-week period to provide advocacy and to be supported by us in going out into the community. So these are community people who are working in the community with a community that understands them, knows them, and they in return understand how the community functions. We've trained over 100 for Fiji, but working within our own community, we have about 12 community health workers. We go out and educate on wellness, and for this we use the SNAP tool, which is about smoking, about good nutrition, about avoiding alcohol, and about increasing physical activity. In response to the work that we've been doing, we were successful in a bid with the European Union, which allowed us to look at a human rights project on strengthening rights of rural women in providing them with knowledge, access, and control of their reproductive health. And this happens by our team going out and listening, and here's Swaran talking to a woman who had come for a pap smear, but really her problem was domestic violence and a disrupted family. and it required a completely different approach as to how we deal with this type of an issue. We've trained staff who can sit down and talk at a one-to-one level. We go to schools. We provide targeted clinical care, which primarily is about screening. We don't provide clinical services other than screening. We provide family planning services. We provide some gynecological advice and services, but no other clinical services. So this unit is primarily for screening purposes. With the work that Swaran and her team did, the UNDP made a chance visit to our health center, and this is Swami's work. They were so impressed with the statistics that were provided that they then went to the United Nations Fund for Population Activity and said, give Visesi a bus. So they didn't give us a bus, they gave us the money, which allowed us to design the bus that we've got now for outreach work. We go to university students. We teach education in human values and decision-making in the community, and we are not scared to share Swami's teachings with the community. We talk to youth. And the Young Mothers program is an interesting program because young mothers tended to be very isolated, and even their families, these are mainly unmarried women, their families did not accept them. So our program was really, and this program was conceived by community health workers, was to try and rehabilitate these women, and almost all of those girls now are in active employment. We nurture the youth, and we educate their teachers about NCD prevention and wellness. We do physical activity and have fun. We have 30 collective community development programs at the moment underway where the community is defining what type of interventions it would like to develop for what particular problem. Our role basically is to help the community become more empowered to deal with its own issues and problems. We have done a substantial amount of work in the last 6 years since we've been established. Visesi Sai Health Center was opened on April the 2nd, 2011, about a month prior to Swami's Mahasamadhi. We were involved in Cyclone Winston support. We were asked to provide emergency clinical services. This is a health center in the periphery that was de-roofed, and we supported this area for about 3 weeks, taking medical students and our mobile bus. We've published so that policies may be influenced. We are piloting tools such as the pen scoring tool, which assigns risks for a major cardiovascular event to high-risk NCD patients, so that we can evaluate whether the work that we are doing is being effective or not, and some preliminary data would suggest that we are showing some impact. We tell the community what they need to do about important issues like Nari Shakti. And that is one of the responses that we have about the high domestic violence rate. And this is making a difference in a small way. But one of our community health workers was able to talk on radio about the domestic violence that she was facing and how her sisters could avoid that by being empowered. We visit very remote areas, and this is about 3.5 hours of rough drive into the hinterland. We work very closely with the community, and the message is that if the roots are good, the fruits will be beautiful. and these are homegrown fruits from the backyard gardens of people. And thank you very much. Our team started with 3 people, and now they're about 25. Sai Ram.
Thank you, Dr. Gyaneshwar. You have established not only a role model clinic in medicine, but also in public health. The California EPA is the only EPA in the United States to have its own EPA. It's different than the rest of the country, in large part because our air was so filthy back in the 1980s. The reason our pictures of our city in Los Angeles look different than the pictures of other cities like Beijing is in large part because of people like Dr. Ganguly, who will speak next.
Good afternoon, ladies and gentlemen. I start by expressing my gratitude and my obeisance to Bhagavan Sri Sathya Sai Baba and to Dr. Narendranath Reddy for his kind offering to present this to you. I'm going to take you completely out of the normal medical fields that you have been exposed to with a presentation on the environment. This is not work environment, social environment, the environment you have with your kids. This environment existed before you had work, before you had kids, before mankind came. I'm talking about the natural environment. I have a number of things to cover, but I may not have time to do justice to all of them, so please bear with me. First of all, let's define what is environment that we have. Our environment is everything that's surrounding us, both natural and man-made. So we have living things, non-living things, we have things that we build, and we have other relationships and so forth that we talked about. But like I said, I'm going to talk about the natural environment. Now the relationship between man, nature, and God is very complex, very intricate, but it is integral to our health, our well-being, our social being, and everything else you have heard of throughout today. So the natural resources that we have are of 2 kinds. One is given by God, renewable, and one is non-renewable, and that can be depleted. So what are the environments? So the environment consists of the air that we breathe, the water that we drink, our climate around us, waste, soil, and many other things, food. We talked about just now the hurricane that Dr. Guntapulli mentioned to us before, and scientists believe that that is a direct result of climate change. We're going to talk about 4 topics today, and I'll do them in short order. Climate change, we'll talk about air pollution, then a little bit about the solutions and what the Sathya Sai International Organization, the organization founded by Swami, is doing to address all these 3 topics. Now, climate change is a term you may have heard before, so I will give you a little bit of 1-minute quick update on what is climate change. Climate change occurs because the radiation coming in from the sun gets reflected back from the surface, and some of it is absorbed right around the atmosphere. Without greenhouse gases, which are in the atmosphere on top, we could not live on Earth. Our temperature would be a very cold, freezing 18 degrees below 0. But our temperature actually is around 60 due to the greenhouse gases up there. Now, one of the problems we have is that we are altering the composition of the gases as existed on the Earth for millions of years. Those little molecules you see floating up there, the red and white, are molecules of carbon dioxide. And those are the ones that give us the climate that we have, this nice, warm, beautiful California sunshine, the Fiji climate, the climate in Australia, Europe, anywhere you have. But what we are doing slowly and steadily is increasing the amount of CO2 in the atmosphere. This chart goes back to 500,000 years. We can extend that to 1,000,000 years. The amount of greenhouse gases you have has never exceeded about 350 parts per million. And now it is over 400, and it is expected to go up to about 500 to 1,000 ppm. So what is the result of all of this? The result of all of this is that carbon dioxide has increased about 40% in about 100 years. Now, what is 100 years in the history? In the history of the Earth or the history of climate, It's a blip. It's less than a second for a human being's lifetime. And due to that, the greenhouse gas composition being changing, there is a slow global warming on the earth. In other words, we are all heating up. The biggest sources are our industrial activities and commercial activities. But the result, as shown on this slide, is that 15 of the 16 hottest years we have ever experienced since we started taking measurements have been since the year 2001, the last 15 years. And what is more alarming is that the last 2 years were the hottest years on history. As we go forward, the potential impacts of climate change are shown up here. You'll be facing food shortage, water shortage, displacement of people. In fact, the United Nations estimates there'll be 50 million refugees by 2050, driven from their homes, like in North Africa, like in India, like in other countries due to climate change, and a host of other activities that will always impact us as we go forward. Satya Sai Baba had said long time ago that today, due to this pollution, mankind is getting affected. And what is important, he predicted the earthquakes, floods, and hurricanes that are coming here long time ago, back in 1990s. And he said that the only way we can correct this, and it is causing diseases like asthma, pneumonia, deafness, etc., is being kind to the environment. Let me switch from climate change to air pollution. This is a matter of life and death because we all need to breathe air. And I work for an agency for the government that clean the air in the Los Angeles area. Why is air quality important? Air quality is important among many reasons because of health effects. Air quality has been estimated just in Southern California, in this area, to cause about 5,000 premature mortality, as well as asthma, lower respiratory diseases, COPD, acute bronchitis, and even contribution to cancer. And the contribution to cancer is a lot alarming than we think of. One of the key markers of the pollution that causes cancer are diesel particulate matter, and the short-term effects are irritation of eye, nose, throat, coughing. But in long term, it not only causes cancer, but also premature death in people with heart-lung diseases, inflammation in the lungs, as well as impacts on newborns and in young children. Now going forward, we have had this fight in Los Angeles for a long time. This is a picture from 1955 showing the level of smog in downtown LA. And since I worked at the district, we have measured how the level of smog keeps coming down here. This is all over Southern California, about 10,000 square miles. These are the number of bad air quality days, or the days we had bad smog. And back in the 1970s, the days were about 2/3 in the year, and now they're close to 0 by any kind of measurement you take. Globally, if you go back and look at the global, you'll notice that air pollution, which is diesel, which is the particulate matter here, and ozone, is ranked one of the top in terms of global burden. If you do a map of the world, then you'll notice that 2 of the countries where there are a lot more death than in any other countries are India and China. And the developing countries here are in between. In the United States, it's not that much because of our environmental cases. And here is a chart showing the number of deaths that are directly attributable to fine particulate matter in 2015. These charts are updated from time to time, and while India and China are getting worse and worse, as well as the developing countries, the United States and other portions of the world are getting cleaner. So there are many solutions to this, and I'll just touch on a few of them. But first, let's remember, there's no place like home, and we have to do our part. And what is that we are doing? First, we have to admit that climate change and pollution is everyone's problem. So no single government scientist can fix it. So we have to change our lifestyle and do things together. Here are some mitigation measures. More efficient use of energy, greater use of low carbon, no carbon energy, and some other new activities. In particular, things like driving fuel-efficient cars, reducing your car use, maybe taking public transportation, using energy efficiency in buildings, and some other things for electricity generation, reduce your carbon footprint and therefore less of greenhouse gases. What is interesting is that Swami has talked about this at length for many, many decades. And if you go back and search, you'll find there are two complete books of his discourses on the effects of the climate and how we can live with it. And I'll read only one of these quotes here. On account of the stupendous temperature of the core of the sun, he told us that you can actually extract the energy that is coming into the earth and use it for peaceful purposes rather than try to pollute the air by using coal, oil, and some of the other resources. A couple of years ago, I came across this slide, which I'm sharing with you. This is the amount of energy that comes in from the sun any given time compared to what is in the earth right now. And 1% of this, of energy, is enough to supply the entire energy need of the earth, all electricity, all fuels, and everything we use for an entire year. And that is leading to greater wind power usage, greater usage of solar energy. This is a particular project in Chile that's generating about 100 megawatts of power. And conservation of electricity, things that we can do very quickly, like reduction of waste, are things that are happening around the world. Now, what is the Satya Sai organization doing about this? Well, the young adults in our organization took the lead, and I'm happy to tell you that they have done quite a bit, like starting to reduce the usage of plastics. And these programs are going around to nearly 2,000 Satya Sai centers and groups around the world that we have through about 120 countries. A new committee has been formed by the Prashanti Council under Dr. Reddy's leadership, and I'm the co-chair of that. And we are going to continue to do this not only for reduction of plastics, but community cleanups. And these are pictures from USA, Hungary, Czech Republic, Lithuania, Australia, New Zealand. If you go on our websites in satyasai.org, and then the Sai Universe website, satyasai.org.saiuniverse.org, you'll see all of these projects described in detail. There are some long-term projects here shown on this particular slide. The environmental committee that we have is trying to take Swami's message of spirituality and protection of environment into practical terms. And we are developing different projects to go forward, provide awareness, information. You cannot adjust without understanding the problem. The first comes the awareness and the knowledge, and then you can adjust, and then you can take action. So our first step to inform. A Go Green conference is being arranged in July 2018 in Prashanti Nilayam, and it is based on Swami's principle of be, do, tell. So first, we experience God in nature, spiritual unity. We'll talk about that. Then we'll focus on facts, tips, sharing of experiences within the organization globally. Perhaps a service project in the local community. And then we share this information and public practices at our public meetings projects, which is a part of our public outreach. And then we'll also have exhibition. You're all invited to come to this particular conference in July and share some of your thoughts. And with that, thank you very much for giving me a chance to talk.
Thank you, Dr. Ganguly. Our next speaker will be Sai Balasubramaniam, a medical student candidate. Those of us who interview medical students or medical trainees, we always marvel that the students who are coming up behind us have better resumes than the rest of us. And Sai is an excellent example. He's an MD, JD dual candidate. Please welcome Sai.
Thank you so much, and thank you to all of you guys for giving me an opportunity to speak today. As you mentioned, I've actually finished my legal degree, and prior to that, I was in strategy consulting for a couple of years, so now coming in as a medical student with somewhat of a unique perspective. And I want to speak with you guys about something that's kind of important to me, which is a loving attitude at work and how to cultivate that in the modern healthcare landscape. And so one of the first things that people ask me, well, I guess people ask me two questions about why I do my degree. The first is, am I crazy? And the second is, what do I want to do with it? And eventually the idea is that I want to bridge the huge gap that there is between physicians and the law. And a huge gap that I feel, that a lot of us feel that there is, especially in terms of advocacy. So a loving attitude at work, what is it? Well, when I was thinking about this concept, I was thinking about how a lot of healthcare leaders and people in this room, and including myself, we take active approaches to achieving a lot of things, specific skills, specific procedures. We really take active conduits to do exactly what it is, and we learn based on measurable goals, and we set up metrics for ourselves, and we achieve based on those metrics. We say, this is how I did this, I failed this test, therefore I have to go back and learn it. But when it comes to something like having a loving attitude at work, I know myself, and I'm sure a lot of you, probably take a more passive approach to this, right? We wake up every day, I would like to think we all wake up every day, and go into work thinking, well, let's be good people today, let's be generous, let's have a loving attitude. But how many of us actually sit down and do metrics-driven results for something like this, right? We go to centers, we go to discourses, we get all these ideas about how we should be better people, but how many of us come back at the end of the week and think about how we should better ourselves and what kind of metrics we should be using to measure something like this? And that's when I really started thinking, what if we all started taking a more active measure in this? What if we actually treated this just like any other skill set and made it something that we work on a weekly basis, just like any other surgical technique or medical technique? And maybe we see results just like we see results in everything else. And what would those results really mean in the grand scheme of things? Because after all, it's a pretty simple concept of loving attitude at work. Be generous, be kind, be forgiving to people that you see around you in the healthcare landscape. But what if we took an active approach? And I want to talk a little bit about this in the modern healthcare landscape, because as we all know, healthcare today is very different than it ever has been, and it's constantly changing. So I want to start with the why. Why should we do this? And then maybe talk a little bit about my own ideas and what I've done to maybe start thinking about the how. So what is the modern healthcare landscape? So I sat down and I thought about what is wrong with today's healthcare system, right? So providers are overburdened, healthcare systems are overburdened, costs are up, patients are frustrated, job satisfaction is low, and overall patient satisfaction is low. And by no means am I underplaying all the great successes that our medical field has brought, but these are kind of the biggest problems that I saw. And when I listed these down, I knew the first three, there's no way that we could ever touch on an individual basis, right? The fact that everyone's overburdened, the costs are up, has simple supply-demand economics behind it, so not much we can do. But what about the fact that patients are frustrated, job satisfaction is low, and patient satisfaction is low? Maybe there's something that we can do on that side. And maybe if we start practicing a loving attitude at work on an active manner, maybe that's something that we can actually effectuate change. And maybe if all of us took that away, if all of us took away a more active life after today, then maybe we could actually move the compass needle on that end. Next slide. And the idea is that eventually we want to be able to do this. Yeah, let's try again one more time. Okay. And the idea, yeah, there we go. Thank you. And the idea is to actively cultivate that attitude to maybe transform healthcare from a commodity into a duty. And if we start seeing it as a duty, when you take this as our job, as we would any other technique that we learn at work every day, and we start making active notes, then maybe we can make a difference here. So overall, this is a pretty macro-scaled goal, right? Why would we do this? What is the carrot? Of course, if we do this overall, sure, you're going to tell me, we're going to see that less patients are frustrated, more job satisfaction. But what is the good for me, right? Why would each of us go away today and make this a personal goal for ourselves? Well, I want to introduce you guys to some of the empirical research of what we could do, or what could really happen to our practices and our lifestyles if we did this. So speaking from the legal perspective, factors that prompted families to file medical malpractice claims. 13% believe that physicians refuse to listen to them. 32% believe that physicians don't talk openly. And 48% believe that physicians were trying to mislead them. Which I think, again, is an interesting perspective when you're considering the loving attitude at work. And what is it that we cultivate with our patient-physician relationships? So these, I thought, were two very interesting studies, very incongruent with my legal training. So two different universities, academic centers, implemented an error disclosure program. And what I thought was very interesting is both of these studies realized that after they implemented formal programs where their healthcare providers disclosed their mistakes to their patients, you saw that the overall costs of liability claims and overall cost of healthcare actually went over time, which is very antithetical to what you hear in the legal field, right? I mean, in the legal field, the first thing that we learn is admission of fault is admission of guilt, right? And you train people to say, don't say sorry as soon as you make a mistake, because that can be used against you in court. Whereas here, you see the research actually showing that when there's a formalized program stating where physicians should actually admit their mistakes, patients are half as likely, if not more, to sue their physicians, which I think is very interesting. So right here, we see a huge benefit to seeing, and these studies were actually pioneered by MD JDs at these respective universities, and I think you see a huge benefit to what the positive benefits of cultivating that relationship with your patients and with your consumers can be. And I think, again, it goes back to making an active progress, an active step in that loving attitude in the work. So what about the medical perspective? Well, time after time, it's been shown that the beneficial effects of a good patient-clinician physician on healthcare outcomes are of similar magnitude to established well medical treatments. And people empirically state that unlike any other medicine, a good patient-physician relationship is probably the best cure ever. And we hear anecdotally, you know, a happy patient is the one that comes out better in the long run. And so maybe, again, there's something to be said empirically about what we can do with this. Doctor-patient communication. Most complaints about doctors relate to issues of communications, not of clinical competency. Patients want doctors who can skillfully diagnose and treat their sicknesses, as well as communicate with them effectively. Again, going back to this idea of the fact that patients ultimately are putting a huge premium on the relationships with their providers, and not so much the medicine itself. So moving on to the how, right? We've talked about why, and we've talked about how we can effectuate macro-scale change as well as change for each of us in our individual practices as healthcare providers. How do we do this? And these are just some ideas that I've been working on as I go through my medical training and areas of improvement that I've found that really work for me. So communication. How are we delivering the content to our patients, and are we listening to them? Yesterday we did a great mindfulness workshop about how physicians and providers and healthcare workers kind of get caught up in the efficiency metrics of having to go fast and seeing more patients, where sometimes we forget the human element of the physician-patient relationship. Empowering the consumers. I know even in legal training, we don't take a lot of time to ever explain, we just do. And so much of healthcare is about doing, not explaining. And we need to keep that in mind whenever we see our patients. Conflict management. I used to have a professor in law school who used to tell me, sometimes it's as easy as picking up the phone. If a lawyer and a lawyer could just talk to each other and cut out the actual plaintiffs of defendants, half the cases would be settled. Sometimes it's just as easy as picking up the phone and talking to someone. Empathy. One of my mentors always used to say, clients never come in on a good day. No one comes to see you as a healthcare provider or as a lawyer on their best day. Everyone is coming to you on their worst day and what they see as the biggest problem. Keeping this in mind can go a long way in developing that relationship. And finally, mentorship. As healthcare providers, we have a great opportunity to teach people underneath us, and teach people around us. And I think this is the next generation of what we need to do, and how to teach our fellows and our students as we move up. So if we can take these different points and make these active metrics and maybe sit down weekly and reflect, what did I do this week? How could I have done this better? Are there any places where I could have maybe not gotten as angry or impatient as I did? Maybe we'll see a change in the long scale. I want to ultimately leave with a great quote by Swami, which I think really envelopes this concept, which is, develop spiritual outlook and treat patients with love and care, and make them happy and healthy. You are under the mistaken notion that mere medicines can cure the disease. If that were the case, what happened to all those kings and rich men who had access to the best medical facilities? I think this reminds us that healthcare is not about curing the body, but it's about curing the soul. Thank you so much.